بسم الله الرحمن الرحيم.
Recording in progress.
I have the pleasure and honor to meet you in the third Endoscopic Ultrasound Congress in Egypt. I'd like to welcome you all. I'd like to welcome the attendee, and I'd like to welcome our colleagues on the Zoom from many countries. First of all, I'd like to welcome my mentor and my professor, Mazen Naga, for his continuous and strong support and encouragement in all fields of endoscopy, especially endoscopic ultrasound. I'd like also to welcome and greet Professor Magdi Dashan, Head of Internal Medicine Department, Azhar University, for hosting the workshop tomorrow with advanced diagnostic and interventional techniques. I'd like to welcome and to thank all the very eminent international professors sharing in the third EUS Egypt and sharing in many events and supporting EUS in Egypt. First, a great professor of endoscopy and endoscopic ultrasonography, Professor Marc Giovannini from France, Marseille, and Professor Hakan Sintork from Istanbul, Turkey, and Professor Malay Sharma from Meerut, India, and Professor Kazu Haraf from Nagoya, Japan, Professor Muhammad Osman from USA, Houston, Texas, Baylor University, and Professor Muhammad Abdel Hafiz from Germany, Munich. I'd like to thank all the supporting companies for supporting the EUS events in Egypt. Our Congress will be 2 days. Today is the first day with very advanced and very advanced lectures, basic and advanced interventional lectures in endoscopic ultrasound with our eminent international figures, and also a very nice video session with many videos from Egypt by our distinguished colleagues in endoscopic ultrasound. Tomorrow there will be a workshop of basic and advanced endoscopic ultrasound with many EUS cases and sampling and cystogastrostomy with metal stents, lamps, stents. And I hope it will be a very interesting workshop from the Al Hussein Hospital from Azhar University. I hope that I can start at this exact scheduled time, 2 a.m. And we will now start by a short video and then go to start exactly at 2 p.m. And I'd like to invite the chairpersons of the first session. ندرس نبتدي بقى دلوقتي إن شاء الله.
I'd like to introduce Professor Marco Giovannini. He will talk about update in EUS guided biliary drainage.
Thank you very much for the invitation. It's always a big pleasure to be with you, and I hope next year to be in person, present in Cairo for the fourth EUS Egypt EUS meeting. Thank you to give me the opportunity today to speak about the update of EUS guided biliary drainage. As you know, here you see the three type of biliary drainage using the EUS routes. The first is the choledochoduodenostomy with the direct puncture of the CBD at the level of the duodenum, the bulbus, or the genius superius, with the introduction of a metallic stent. The second is the hepaticogastrostomy, which is mainly indicated in case of altered anatomy or in case of duodenal involvement, using the route, the transhepatic route, with the puncture of the left hepatic duct, segment 2 or segment 3, and the introduction of a special stent to assure a communication between the left lobe and the stomach. And the third technique is the anterograde stenting. Is the same route than the hepaticogastrostomy, but the stent is pushed anterogradely through the papilla. Now we know that we can use special lamps to do choledochoduodenostomy, and this is a short video about using lamps with the direct puncture of the dilated CBD. And the opening of the stent is very quick, but you will see in the literature that this is not also the panacea. And here you see this stent open in a bulbus and the EUS image. Anterograde. I'm sorry. Anterograde stenting, it's sometimes useful when the papilla is not involved and if the cannulation fail. I prefer the anterograde stenting than the rendezvous technique, because sometimes the rendezvous technique is a little bit tricky due to to advance the wire, and here you see that it's quite easy to push the wire through the papilla and through the stenosis. The only trick is to know where is the papilla, and one trick is to push the stent in the duodenum, to open a little bit the stent, and after to pull back the stent. And when we have a kind of a resistance, you know that you are at the level of the papilla, and after it's easy to deploy completely the stent. Now hepaticogastrostomy, I will show you this case. This is the very difficult case, because I did this case during my lab course. It was a patient with, as you see, with a duodenal involvement, with a metallic stent into the duodenum, a previous metallic stent in the bile duct, and plastic stent, and the patient has a recurrent cholangitis, but the ducts are not dilated. You see, we have multiple air inside the bile duct, but even if with this aerobilia, even with the duct are not dilated, with the progress of the EUS image and the quality of the EUS scope, we use in this case the new generation of Pentax scope. It was possible to target this very small and non-visible bile duct, and to obtain and to try to put an hepaticogastrostomy in this patient. Of course, it's easier when the bile duct is dilated, but I'll show you this is this extreme case, because this technique is very useful. You see, we have here the injection of the bile duct. This is the first step of the procedure. It's the opacification using a contrast. And you see here the contrast going into the CBD. And after the second step is to pass the guide wire. Of course, we need to have a good X-ray machine to target the tip of the guide wire and here you see we need some manipulation because the ducts are not so dilated. But finally, we succeeded to pass into the small bile duct and to go into the CBD like this. And the next step will be to create the anastomosis using the 6 French cystostome. The 6 French cystostome is very useful because you can use using a pure cutting to create this anastomosis between the bile duct and the gastric cavity, and also we can inject contrast to be sure that the guide wire is in good position. Here you see the cystostome. And here you will see the injection of contrast here to be sure that we secure the position of the wire. We are sure that the wire is in good position. And the next step is the introduction of the stent. Of course, we need a special stent. This is the second generation of Jobor stent, which is partially covered stent, 30% uncovered and 70% covered. And this new stent prevents the risk of bile leakage. Here you see the stent with the first mark here and here. This is the uncovered part, and this part is covered. And now the technique of delivery of the stent has changed. It's not necessary to see the opening. The technique is to open the stent completely in the working channel of the scope, and after to deliver the stent, to push the stent outside. You will see on this video, and this prevents one complication, so-called the candy sign. I will show you after my presentation, which is the candy sign. And here you see the stent is the opening of the stent, and you see now the technique to open everything inside the working channel, and after, and this also prevent the risk of migration into the peritoneum of the stent. I will show you this. And now you see the endoscopy image. We push everything with the catheter. I'm sorry that the image now is not so good here. Here you see, and we are pushing we push the stent inside the gastric cavity, and the anastomosis is done. We have a different clinical situation now to use the EUS guided biliary drainage, the malignant stenosis of the CBD, the benign stenosis and CBD stone in altered anatomy, and the malignant hilar stricture. The first word is the malignant CBD, the lower part of the CBD, mainly pancreatic cancer. You have in the literature today many papers, and this is a systematic review, a meta-analysis showing that the choledochoduodenostomy is safe, with today a pool of adverse event of less than 14%. And if you use lamps, the risk of adverse events seems reduced in this meta-analysis. Now there is no discussion. EUSBD is better than PTBD. EUSBD is associated with a better clinical success, fewer post-procedure adverse events, and lower rate of reintervention. And today, when the RCP failed, it's quite necessary to perform an EUSBD and not to perform PTBD. Safety of choledochoduodenostomy using LAMS. We have 3 recent studies, and you see that the percentage of success is quite high, but we have a percentage of complication around 5 or to 6% and a late dysfunction. But late dysfunction is probably more than reported in this paper. And you have this kind of dysfunction is the small lumps of 6 or 8 millimeter is completely obstructed by just the bin, you see. And you understand why this is the comparison of these very small lumps versus the SEMS. And this occur in around 35%. And even if it seems that it's easy to perform, the lumps has the same problem than the old choledochoduodenal anastomosis performed by our surgeon with the risk of reflux of food and food impaction. And this is a very recent paper because it was published during in October in Endoscopy. This was a meta-analysis. They compare the choledochoduodenostomy using LAMS or standard SEMS. And you see there is no difference in terms of technical success, clinical success, complication rate. This is the best, the real complication rate is around 17 and 18%, and the reintervention rate. There is no difference between LAMS and SEMS, but in terms of adverse event, there is a higher rate of perforation with LAMS, and this is due to the technique of delivery of the stent, of the axial stent. We need to have a large CBD around 15 millimeter to deliver with less risk of perforation of the CBD with the system of delivery of the stent. Choledocho or hepatico, there is 3 papers in the literature. 2 show no difference in terms of clinical success, technical success, and complication. Just 1 from Europe showed that there is a little bit more complication in a group using the hepatico-gastrostomy route. What is globally the safety of the EUS guided biliary drainage? You see that the problem is not the percentage of complication. If you see, this is the whole paper published. If you see the problem is the type of complication, and the type of complication is bile peritonitis, which is very difficult to manage, in particular in patients with advanced pancreatic cancer. And to reduce this risk, we have now a new stent. This is the new Jobor stent, and with this partially covered part, we have reduced the uncovered part to 3 centimeters. This is necessary to anchor the stent inside the bile duct, and the covered part, the long covered part, prevent the bile leakage. And this is the results in your paper that we published 4 years ago. Now, no bile leakage in 31 patients using this kind of stent. But the future is to reduce again the complication rate, and we need to have a best selection of the patient. Ascites is for me a contraindication. It's better to use a cystostom than to dilate with a balloon. And also we need to have a new design of this stent for hepatico-gastrostomy to combine LAMS and Jobor stent. And this is the stent that we will have very soon in the future. It was a stent like the Jobor with the 3 centimeter uncovered and 7 centimeter covered, a large flange in the stomach like the Spaxus or the Axios stent, and also a hot system to insert directly the stent without the need to use a cystostome. And the goal is to reduce the number of manipulation. And if we reduce the number of manipulation, we will reduce the risk of complication. And just to finish on the can design, and this is the can design. The first can design was described for a pseudocyst drainage. Is in fact the part of the stent is into the peritoneum. And this is into the stomach, there is in the cyst, and this is into the peritoneum. And we have the same problem with the choledochoduodenostomy in this case. You see this part is in the peritoneum, here in the duodenum, here in the bile duct. But this, if you leave the stent like this or like this in hepaticogastrostomy, you will have a migration of the stent, because due to the movement of the stomach or the duodenum, the stent will migrate. And the trick is to, when you have this sign, is to insert a second stent inside to prevent the migration, a long second stent inside the previous stent. Of course, to prevent this complication, the technique is to intrascope channel stent release. ERCP BD versus EUS as a first line for the drainage of malignant stenosis of the lower part of the bile duct. 3 small randomized studies. The conclusion was that it seems that the EUS BD is equivalent or superior to the ERCP in terms of complication, because of course there is no acute pancreatitis in EUS routes. And this, but if you see this 3 meta-analysis, they show that there is no difference in terms of clinical success and in occlusion rate, but the type of complication, again, bile peritonitis, are more severe in the EUS group than the ERCP. And today, I think it's too early to replace the ERCP as a first line for the drainage of malignant biliary obstruction. Benign stenosis, just to show a case of the use of the EUS. This is a case in which the papilla was not found, and the patient has acute pancreatitis due to a CBD stone. You see the CBD is not dilated because this patient has no malignant obstruction, but this is the technique of rendezvous with the direct puncture of the CBD with the 19 gauge needle under EUS guidance. And after we obtain the cholangiogram, and it was possible to pass a guide wire into the duodenum. I'm sorry. I don't know why we don't see the guide wire. To pass the guide wire, and after to exchange the scope. Here, you see the guide wire. Pass into the duodenum, and after it's easy to exchange the scope for a duodenoscope to cannulate and perform the sphincterotomy. In the literature, there is very few paper about the EUS biliary drainage and a benign situation. It's mainly in patients with altered anatomy and in patients with anastomotic biliary stricture. And as this patient, he has a stricture of the biliary anastomosis after Whipple resection. And you see the first step is to insert a fully covered stent as an hepaticogastrostomy. with a double pigtail. And after 1 month, we can remove the fully covered stent, and we have a direct access to the bile duct and to the anastomosis, and the anastomosis is dilated using a plastic stent. Or like in this case with a previous gastrectomy, the patient has a huge CBD stone. Same technique. First of all, we insert a long, fully covered stent, and 3 weeks after it was possible to pass. Here you see the spyglass to do a lithotripsy of this stone, and after with a macro dilatation of the papilla, we can push the stone and the debris of the stone inside the duodenum using here the spyglass. My last part of my talk is malignant hilar structure, and one question is how to drain the right lobe using the EUS. This is the main question today. We use the EUS for the hilar tumor like this, and the right lobe was drained endoscopically and the left using the EUS. Like in this case also 3 stents in the right and type 4, and the left is drained using the EUS route, and we have this complete drainage of the patient. We can have this kind of montage with 2 hepaticogastrostomy in the segment 2, segment 3, and 2 or 3 stents in the right. And sometimes also like this, and 2 hepaticogastrostomy and 2 stents in the right lobe. But to drain the right lobe using the hepaticogastrostomy route, it's the bridging technique. I will show you this video. It was a patient with a type 2 Klaskin tumor. It was not possible to cannulate the papilla. The first step is the puncture of the left lobe to obtain a cholangiogram, and after to insert the wire. Here you see the wire is the level of the CBD. After with the cystostome, we can insert deeply the cystostome at the level of the stenosis, and using an angulated wire, we can pass into the right lobe like this, deeply, and using the pure current, we create a small channel through the tumor, and to insert deeply the cystostome in the right lobe. And the cystostome is very useful because we can inject contrast and to obtain the injection of the right lobe like this. The next step is to perform a dilation of the stenosis of the tumor using a 4 millimeter balloon. Here, you see the dilation, and we proceed to the insertion of the first stent, which is a 6 centimeter uncovered stent. This stent will permit to do the communication between the right lobe and the left lobe. Of course, we can use a 4 centimeter or 6 centimeter. This depends on the anatomy of the patient. And here you see the opening of this stent. And after, we will put an hepaticogastrostomy, 8 centimeter Jobber stent to drain the left lobe into the stomach, and we have a complete drainage of the liver. Here, this is the opening of the hepaticogastrostomy. Yeah. And this is the final results with the complete drainage of the liver into the stomach, the right lobe into the left and the left into the stomach. We have only 3 papers in the literature using this technique, and you see that the percentage of clinical success is around 80%. just to stress you that you need to combine all type of procedure to drain as much as possible patient with complex biliary stricture, because if you try to drain more than 80% of the liver, this increase the survival rate of the patient. Just to conclude, in case of failure of a RCP, if the duodenal lumen is intact, we perform choledochoduodenostomy or anterograd stenting. I prefer for the choledochoduodenostomy to use a standard SEMS. For duodenal obstruction or previous surgery, hepaticogastrostomy with the Jober stent 10 centimeter. And if you are interested, please, we organize next year in September our course, and I will be very happy to receive you in Aix-en-Provence, a very nice city close to Marseille. Thank you very much for your attention.
Thank you very much, Professor Giovannini, for this very valuable and updated lecture. Now 3 minutes for discussion. I have an important question, at least for me. What is the best wire, the best type of wire you advise to use in all maneuvers of biliary drainage?
I use 3 types of different wire. The first is the standard jag wire or the angulated jag wire 35. When the ducts are not so dilated, I like to use the new Revolution 0025 from Boston or the VisiGlide 25 from Olympus.
Do you prefer some type of these wires, especially in case of the bridging?
Yes, I use the rigid, not super stiff, but stiff wire. After depends if the puncturing tract is very perpendicular to the bile duct, I prefer to use an angulated wire to pass easily. If the needle is is parallel to or in the same direction than the bile duct, I prefer to use a straight wire.
Okay, thank you. Another question, during rendezvous maneuver, almost always or usually, for me at least, the wire is directed up in the proximal CBD and the liver, because there is a J-shape of the echo endoscope inside.
Yeah.
What is that?
I have no very good solution. No solution. Again, the best is to use a wire that you can with an angulated wire, you can change the angulation of the wire using the torque device.
Yeah, torque device and angulated wire. Okay. Any questions?
Thank you, Professor Giovannini, for this highly advanced cases. I'd like to ask about the minimum diameter of intrahepatic biliary radicals.
5 millimeter.
Yes.
No, man. Today we can perform hepaticogastrostomy, but the main indication is when the ducts are dilated. I think 5 millimeter. It's a good and more, of course. It's the good size to perform hepaticogastrostomy.
And thank you very much. Now,
thank you
for this very updated, and excuse us if I have questions arising during our practice. I can contact you personally to know you're great, to get benefit and your advice. Your great experience in the all fields of endoscopic ultrasonography, especially EUS guided biliary drainage. You have pleased and honored to see you and hear your lecture, and hoping that in the next year in Egypt you will be with us and will do many of cases. Thank you very much, sir.
Thank you. Have a good meeting. Bye.
Assalamu alaikum. Good afternoon. The next speaker is Professor Hakan Santurk. You hear me, Professor Hakan?
Yes, I hear you.
For me, it's good to hear from you. We are happy to hear from you, me and Dr. Hussein, Dr. Mazen, and all of us in Egypt consider Professor Hakan one of us. He will talk about nicely titled presentation, EUS Guided Gastroenteric Anastomosis. Please, Professor Hakan, the mic is you.
Thank you very much. It's a pleasure to be with you again. I actually congratulate Professor Okasha, Professor Hazem Hakim, and all the other colleagues for their efforts to advance the science of EUS in Egypt. In the next 20 minutes, I am going to summarize the data in relation to EUS-guided gastrojejunal anastomosis for gastric outlet obstruction, which is not infrequent. It happens in 60% of the patients with pancreatic carcinoma. It also happens in stomach carcinoma, duodenal malignancies, and outside obstruction, such as from peritonitis carcinomatosa. It also happens in benign conditions as well. In this context, the first question will be that, so in this case, we have duodenal stent, and what is wrong with duodenal stent that we are looking for other methods? There's a high migration rate in duodenal stents. There is tissue ingrowth and occlusion. There is a potential risk of papillobacterial obstruction-related pancreatitis. And in this case, we are also obstructing a potential future ERCP route as well. Clinical response is not perfect, and sometimes obstruction may be impossible. We cannot pass the stenosis or obstruction with guide wire. In this study, which compiled too many cases from different centers, enteral stent was compared to EUS gastrojejunal anastomosis and surgical GJ. And as you see, the patency rate is perfect with EUS GJ. And surgical gastrojejunostomy is near, but enteral stents, duodenal stents are faring significantly less in comparison to gastrojejunostomy. Another study comparing surgical gastroenterostomy against EUS-guided GJ, and as to post-procedure complications, recurrence of obstruction, and all-cause mortality, there is no significant difference between the techniques, but you see surgical gastroenterostomy is a highly invasive technique, and the patient should should stay in hospital for a longer time, and complication rate in some cases may be higher, even if it's appeared similar in this study. So EUS-guided gastrojejunostomy at least is not inferior to surgical gastrojejunostomy. Because this is an emerging technique, the technical success rate is highly varied, and you see between 40% and 90% results were revealed. As to clinical success, it is the same from 30% to 100% clinical success rate. And the pivotal part of this procedure is the potential adverse events. And adverse event rate has been reported between 7 to 20%, so it's highly variable. And need for surgical intervention is between 13 and 33%, is a significant mortality rate, procedure-related mortality. But the important part is that 75% of all complications are happening is happening to the operator less than 15 cases of experience. 85% is happening to operators with less than 25 cases of experience, and 90% of the complications are happening to operators less than 40 cases. So after 40 cases, the complication rate is decreasing significantly. This study appeared very recently in gastrointestinal endoscopy. Actually, it is ahead of print, and they actually collected data from most of the centers in the United States and Europe that this procedure is performed. And what they found is that there is a 10% stent multiploidment rate. This is a very high percent, so it is happening in quite experienced centers. So one should be very cautious against this. And most of these multiploidments happen to inexperienced operators. And they further classified the type of multiploidments. And type 1 is that the proximal part is in the stomach, but the distal part is in omentum, in peritoneum. But the enteral part is patent, no damage to jejunum. In type 2, the distal part is again in peritoneal cavity, but there is also damage to the jejunum. This is more complicated and difficult to manage. In type 3, the distal part is located in the right place, but the proximal part is the wrong place. And in this fourth type of complication, which happens quite infrequently, the first part is, this proximal part is in the stomach, but the distal part is not in jejunum, but in transverse colon. And I'm going to show you a case that this is not impossible, so it is very near to stomach, and you can wrongly cannulate, puncture transverse colon. But if you recognize this, no problem. But if you do not recognize and put a stent, so you are having a gastrotransversotomy. In the beginning, we used to perform the procedure with these double balloons. It was quite cumbersome because in the first place, we put a double balloon endoscope, a long type of endoscope, or a pediatric colonoscope. And we dressed this scope with an overtube. Then after inserting the guide wire, we pull the endoscope and we insert an double balloon over the wire. Otherwise, it will entangle in the stomach. So an overtube is necessary. Then you put the double balloon in jejunum, and then you continue with the procedure. I am going to show you a video. You see the double balloon is in its place here. So we pinpoint the proximal jejunum. This is the fourth part of the duodenum. Then we puncture. You see we keep the scope in straight position. Balloon. We first inflate the balloons and then we fill the in-between area with contrast water and methylene blue mixture. Puncturing with 19 gauge needle. Dilation with 6 French cystotom. And finally, opening the stent. And after some time, in this patient, actually, even in 1 week, a fistula developed. When we retrieved the stent, the fistula was over there in such a short time, but we waited at least for 3 to 4 weeks for the forming of the fistula. But in this case, interestingly, the fistula was matured in even 7 days. And we further dilate the tract with 20 millimeter balloon. So this is a very comfortable gastrojejunostomy. But later we decided that this procedure was difficult because you first put the balloon, then you position it, then you puncture it. So it will take at least 1 hour or more. Then we decided to puncture directly. Actually, before direct puncture, in between, we tried nasobiliary tube. We first put a guide wire, then we put a nasobiliary catheter, then we inject contrast here, then we perform the procedure. But this was also difficult. So we decided to puncture directly the fourth part of the duodenum or the proximal jejunum. This part is quite comfortable because you see that there is a Treitz ligament, and because of this Treitz ligament, this area is quite fixed. If you puncture another side of jejunum, you can push it when you push the needle. But if you puncture here, this area is quite stable and it is not pushed into the abdomen with the pressure of the needle. Now I am going to show you some technical details. This is the position of the scope. We find the target jejunum. We are at between 45 centimeters and 55 centimeters. So the target is in our view between 45 and 55 centimeters from teeth, and mostly around 50 centimeters. And we change our position to this position. It is quite comfortable. So we start the procedure mostly in this position. The knobs are in neutral position. The scope is 50 centimeters from teeth. And the target intestine is just less than 10 millimeters to the stomach. That is the perfect position and perfect puncture site. I am going to show you the part we puncture in a demonstrative video. This part is the proximal jejunum just after the ligament of Treitz. We did not inject anything yet. And you see in this study, there was no difference between direct puncture or injecting contrast beforehand. So as we have observed, there is no need a previous filling of the jejunum before procedure. This is the case we performed in the last MINA meeting. This is the jejunum, and here fourth part of duodenum, very near. We puncture and we fill the jejunum with contrast. We deeply place the guide wire, 0.035. Then we dilate with cystotope. We again inject contrast through the cystotope to make sure that we are in the right place.
Yes, now we are deep inside.
And we place an enteric stent. This enteric stent is 20 millimeters, a very large stent, and 8 centimeters. 20 millimeter with 8 centimeter length.
Yes, gastrojejunums we rely on.
The procedure is complete. Then we dilate the stent with 15 millimeter balloon. And in order to make sure that we are in intestine,
yes, you see the intestinal lumen.
We put a pediatric gastroscope.
Yes,
Yeah.
it's okay.
Yes.
This was a patient who developed obstruction of gastrojejunal anastomosis after Whipple surgery. Actually, a few weeks after surgery, and the surgeon was in difficulty because of the previous operation, so he didn't want to perform a second procedure, and he referred the patient to us. And from the remnant of stomach, we entered into the jejunum. We put the, again, 20 millimeter stent. Again, an enteric stent. We always use enteric stent because lumen-opposing stents are very expensive. And furthermore, these stents are larger than lumen-opposing stents, 20 millimeter. Better, fully covered. And when we return and withdraw the stent after 4 weeks, there is a major gastroenterostomy. The surgically created one is obstructed, but ours is working very well. And now you are going to see the site of Brown anastomosis, which was performed in surgery. So the patient was saved from a second operation. I am going to skip this patient. What about to perform the procedure in the presence of ascites? In general, presence of ascites is considered a complete contraindication for EUS guided gastrojejunostomy. However, it can be performed after ascites was removed before procedure. But we should take into account that the presence of ascites increases the risk of septicemia. And if it develops after procedure, it may cause dislodgement of the stent because of the increased area between stomach and jejunum. But in this study, there was no difference between performance of the EUS GJ in patient with or without ascites. And this is one of our patients with ascites. This is our target. A large volume of ascites is present. And we are injecting contrast. But you see that after injecting contrast, what we see is that the picture is somehow weird because this is not jejunum. This is transverse colon. So we punctured the transverse colon. However, because we noticed that this is transverse colon, we changed the site. And this time, we have found the right place, the jejunum. And we put the stent successfully in this patient with ascites. And in these cases, if you notice that you punctured transverse colon and you change the site, no problem. Nothing happens, even if there is ascites. And again, balloon dilation. In conclusion, Mr. Chairman and colleagues, EUS guided gastrojejunostomy is a preferred technique for gastric outlet obstruction in case the right environment is available. What is right environment? Is that operator must be experienced in notes and should not panic and not rush to surgeon if something happens. So you should have all the necessary means to manage the complications, such as over-the-scope clips, and you should be ready to go into the peritoneal cavity with your gastroscope to remove a migrated stent if it is necessary. So not only performing the procedures, but performing what is necessary for complications is important as the technique of the procedure. Its learning curve is steep, and most of the complications happens in this period, in learning curve. To be proficient, one should perform 25 cases, and for mastery, 40 cases is necessary. And as I said previously, all necessary accessories should be in handy position to manage the complication. And finally, our next meeting will be in the context of our National Hepatogastroenterology Congress in Cyprus. We are going to have a live demonstration from Bezmi Alem, 20th May of the next year. So all welcome. Probably we are going to have a panel in the core meeting as well. I am going to inform you, but please now on you make a note about these dates and do not engage in anything other than MENA meeting in this period. Thank you very much.
Thank you. Thank you, dear Professor Hakan, for this elegant presentation as usual. We have only 5 minutes for discussion. Any questions from the floor?
Yes, I have a question, please. First, I'd like to greet my dear professor and the brother, Professor Hakan Sentork, for his continuous support of endoscopic ultrasound in Egypt. And I am always saying that it is a pleasure and honor to meet him anywhere and anytime. Congratulations for the new technique of gastroenterostomy with the much cheaper stents. But I have just 2 points. The first point is you are doing a very difficult and distinguished job to puncture a collapsed small bowel, by 19G needle. It is not easy at all. It needs a great experience. My question is, why not to pass a nasobiliary or even a dilator to inject some fluid in the duodenum through the stenosed pyloric ring, and to inject also methylene blue and dye in this fluid even after puncture. The puncture will be very easy with the dilated bowel loose, and also you can aspirate methylene blue so you can be sure that you are in the right place in the small bowel and not the transverse colon. My question is, why not to do that? Is it a difficult maneuver sometimes, or wasting time, or what is your point in that not to inject fluid in the duodenum at first?
Thank you very much. Actually, great question, because first of all, as I told you, in order to insert an nasobiliary drain into the jejunum, first of all, we should put the double balloon, we should put an overtube. But for nasobiliary drain, it is not necessary, because you can put it directly from the biopsy channel of the scope. However, what we have found is that when you put the nasobiliary drain and if you inject contrast, the area is becoming more complicated. So too much contrast fluid, and it is more difficult to target the part you want to insert the needle. That is our experience. So if you want to do it, the perfect strategy would be that you only infuse water and methylene blue, not contrast material. Because if you infuse with the contrast, the area will be filled with too much fluid and contrast, and it is more difficult to puncture the right place. And actually, because of this, we sometimes fail to puncture. And what I see is that even if it is collapsed in a few attempts, at the most in 5 or 6 attempts, it is possible to puncture the fourth part of the duodenum or proximal jejunum. So my personal experience dictates that you either feel beforehand with only water and methylene blue, not with contrast, or you do it directly. But my personal experience is that doing it directly is better. After performing the puncture, you can of course fill it with any amount of fluid you want necessary, but I don't think it needs some exaggeration to say put 200, 500. It is not necessary. But as you say, in order to puncture a collapsed part of intestine, you should be quite experienced, and it requires that you do a very brisk push to go into the duodenum, the fourth part of the duodenum or jejunum. That is my experience.
Okay, another more complex question. Do you follow this technique in not injecting in the jejunal loop if you will use Axios stent, if you will use Axios or lens, whether Axios or Axios? Do you perform this technique not to inject? Because I think it is very difficult for Axios to puncture the stomach and then the small bowel with not enough dilated small bowel. So I know that you are following this technique. If you use the special type of stent, which is the colonic stent you are using, but if you use hot Axios, you also follow this technique not to inject water in the jejunal loop?
Actually, great question again. Of course not. Yes, you are perfectly right. If you are doing it with Axios stent, then of course you should fill it with at least water and methylene blue. But because I do not use Axios and I puncture with 19 gauge needle and I put enteral stent, I do this. But if you of course use Axios stent, you should fill it with at least water and even maybe contrast. But my perspective is that Axios stent is not the perfect one here. Why? Because you are going into an uncharted territory without knowing where you are. So if you puncture the wrong place, so that will cause some leak. And because of this, I think that in taking into account the cost and the larger width of the enteric stent, first puncturing with 19 gauge needle and then dilation and enteric stent is equal or better than lumen-opposing stent.
Okay.
Thank you, Professor Hakan. I notice you use a tubular stent, I think a colonic stent. Do you dilate after puncture with after making the track with cystotome? Do you dilate with a balloon or introduce the stent directly? As you know, this stent is have a big delivery system. It's easy to pass after 6 French cystotome, or you need to dilate before that?
Yeah, that is again very good question. Actually, this is a 10.5 French introductory system, so it is quite thick, and because of this, we try to keep the scope in the straight position. Otherwise, we cannot insert it. But of course, the Axios stent is also 10.5, so no difference. In some cases, it is possible to insert it without any dilation. So my procedure, my technique is that I first insert the stent without any dilation, but if the stent is pushing jejunum and if it is not entering easily, then I withdraw it and I do dilation with a 40 millimeter Boston Scientific balloon. But if you do it beforehand, I mean, before inserting the stent, of course, you can do it easier. But in at least more than half of the cases, I enter the intestine with stent without any previous dilation. But of course, you should not push hardly, otherwise you would dislodge the guide wire. So if there is a resistance, you retrieve the stent and you do balloon dilation for the intestinal part.
Then thank you very much for the very valuable lecture with new technique and new modifications, many modifications. Of course, it needs a great experience, but it is much less expensive than using the
human apostatics.
Thank you very much. Always a pleasure and honor to see you.
Thank you much. But my pleasure, and I hope that in the next year we are going to be together again in Middle East North Africa meeting. Thank you.
Okay, thank you. Next lecture, I have the pleasure and honor to invite our dear colleague, Professor Mohammed Osman. He is a very good friend of Egypt and is helping us very much in propagating and promoting endoscopic ultrasound in Egypt. He will talk us about a very interesting subject for me, because in Egypt we are running many studies in that aspect. And I think it is the future. It is the item of fatty pancreas and whether it has a relation to the metabolic syndrome like the fatty liver or chronic pancreatitis or even cancer pancreas. So I am very interested to hear this subject. Most welcome, Professor Mohammed Osman from Baylor University, Texas, Houston, from the United States. He will talk us about updates of fatty pancreas. Please.
Thank you, Dr. Aukash, and everyone. It's always my pleasure to join the EUS conference. And thank you, too, for teaching a lot of generation EUS in Egypt. And I will tell you something. My fellow loved your video about the EUS liver segment. This video is going viral. A lot of people watching it. I was talking to Ma'in Khashab, and he told me, I watched this EUS liver video for one of the Egyptian professor, and really it means this person has a lot of experience. I want to know him. I told him, I will introduce you to Dr. Aukash. I told him we can learn a lot of diagnostic from him. So thank you for all what you're sharing too online. It is really helpful for a lot of people. I make sure now that my fellows watch your videos. I tell them we have to watch Dr. Aukash video and learn a lot from it. We'll start talking today about fatty pancreas. And it is a topic that I stumbled upon. Basically, something was not planning to work on, but it's just like when you see it often, and I will tell you the story of why this happened. So when we say fat in the pancreas, the first description of fat of the pancreas was in 1933 by Ogilvy, the same one who had the Ogilvy syndrome. And he found that in postmortem, 19 pancreas of obese patient and 19 control. And he found that in the obese cadaver, they have higher amount of fat control compared to the control, which means that obese patient deposit the fat in the pancreas as they deposited in liver and everywhere else. And later on, this observation has been happening and no one really paid attention to it as it is something that it means or need consideration. Before we talk a little bit about fatty pancreas, I want to give a background. The chronic pancreatitis, as we know it, we think about calcification, we think about pain and insufficiency, and that's, yes, a typical picture of chronic pancreatitis. But honestly, this only happened in 50% of the patient, because most of the patient will have fibrosis. And that's what we see in endoscopic ultrasound, these hyperechoic strands and foci and lobulation. That's what we call the early chronic pancreatitis, before the pancreas become calcific. And many of the patients would have this picture, and they will have symptoms too of a syndrome, we call it API, exocrine pancreatic insufficiency. And most of my work in the field was in that part, diagnosing chronic pancreatitis early, teaching people the difference between calcific and non-calcific chronic pancreatitis, and how it is important to know that chronic pancreatitis could be found in EUS where your CT scan is totally normal. Our radiology friends will read it normal pancreas, no mass. You do an endoscopic ultrasound, and you'll find this band of fibrosis. And we do see them in ultrasound as hyperechoic strands and foci and lobulation, hyperechoic duct wall. We call that the Rosemont criterion. But when you say about fatty pancreas, it's basically the pancreatic tissue, as we can see here, replaced with adipocyte, or the adipocyte is fighting to find a place in the pancreas, as we can see in this image here. That's exactly an ultrasound, how it looks like. You'll tell me, how can you know that this is fatty pancreas? The pancreas is too white, and you can compare it to the other retroperitoneal structures. You can compare it to the spleen, you can compare it to the kidney, and you will find here that the pancreas is just so bright. This is an example of a patient I did recently for pancreatic cyst. And this happened a lot for us as ultrasonographer, endoscopic sonographer, that we get busy with the finding. Like here, when my fellow was doing this case, she was so obsessed with the bilobe cyst, but this patient has a background of fatty pancreas everywhere. So yes, so you might find that many sonographer or endosonographer will stumble upon fatty pancreas. They wouldn't even comment on it. So you could get busy with the cyst, describe it very well, and then you don't notice the background of the pancreas. So one of the main things and the main message about this lecture, especially for the one who are doing EUS in every day, is start paying attention to this diffuse homogeneity in the pancreas and hyperechoic. You'll find the pancreas is totally bright and white. And when we find that the pancreas is that bright and that white, even if you have other finding, you should report it. Patient could have pancreatic mass and fatty pancreas. Patient could have chronic pancreatitis and fatty pancreas. And patient could have pancreatic cysts and fatty pancreas. And what happens a lot is that we really go into describing cysts and and we don't tell the patient that they do have fatty pancreas. And I feel that that has an implication, and I'll show you why it's important to tell our patient about it. So when we think about fatty pancreas, there's two terms here we have to clarify. There is a fatty replacement of the pancreas, and there is a non-alcoholic fatty pancreatic disease. And the fatty replacement, basically the pancreas is dying and replaced with fat. And this happens if you have a patient with severe acute pancreatitis, and if you are doing a lot of necrosectomy, you'll find what we call the fat necrosis. You have a lot of fat necrosis. This tissue will be totally, this area will be wiped out. Patient will have no body and tail of the pancreas, and later on, this area will have fat in it. We call it fatty replacement. It also happens in alcoholic. Patient who have viral infection is totally different than fat accumulation within the pancreas, because fat accumulation with the pancreas is that's what we call non-alcoholic fatty pancreatic disease. So basically, in this lecture, we're talking about that type. And that's why the word fatty pancreas is a very general term. And I think very soon we're going to stay away from using it the same like the liver, and we'll call it non-alcoholic fatty pancreatic disease. And that's the one that's common with obesity and type 2 diabetes. So I'm going to tell you the story how I stumbled upon doing this and got into the fatty pancreas. So part of my protocol in finding patients with early chronic pancreatitis is that we're looking for clues for chronic pancreatitis. A lot of time, it's not easy to diagnose chronic pancreatitis easier, because also you need to do an endoscopic ultrasound, and sometimes patient may develop this pain. You cannot know what's going on. So we have to find non-invasive method to screen patient for who would need endoscopic ultrasound in my institution. And we know that you can stimulate the pancreas by two methods. One of them is to give the patient high-fat diet. It's almost like running in a treadmill to stimulate the heart. You give the patient too much fat so that they stimulate the pancreas. And the 72 hours stool test is very tough to do. Or you can do the pancreatic function test, which is similar to the dobutamine stress test of the heart. When you give chemical to stress the heart, you can give the pancreas secretin to stimulate the pancreas. And when we give secretin to stimulate the pancreas will secrete bicarb or collect that when we're doing EUS. I call it dynamic EUS exam. And I do it really if I want to know if the patient has chronic pancreatitis or not. But it is very expensive and also invasive. And honestly, I don't do it outside of our NIH trial, the National Institute of Health trial. So there's another test that stood out as a nice test, fecal elastase. And fecal elastase is basically a stool. You find it in the stool, an enzyme secreted from the pancreas. Elastase is an enzyme to break down the elastic tissue, and it is very strong that you can find it in the stool, and you can use it as a surrogate marker for pancreas function. So why we are not looking for fecal amylase or fecal lipase? They're also secreted by the pancreas, because by the time they reach the stool, they will be degraded and you're not going to find them. So maybe in the stool, there is no remnant of the pancreatic enzymes except fecal elastase. So I'm using the fecal elastase as a surrogate marker to diagnose what we call pancreatic insufficiency, that the pancreas is not secreting enough pancreatic enzymes. And our protocol is better. If I have a patient with any suspicious of pancreatic disorder, you can say gastric pain going to the back, diarrhea, severe bloating. We did a study about doing fecal elastase in all this patient. We recently even had a study in doing it in patients with irritable bowel syndrome, and we found that 5% of them will have pancreatic insufficiency. 7% of them. So this one of our study showing that the fecal elastase, although it is not 100% accurate, it has a sensitivity of 77% and a specificity of 88, which is better than nothing. So we start doing a study about, let's do the fecal elastase in all this patient, and whoever have a positive fecal elastase, we'll take them to have an ultrasound examination. So the story starts as patient will come to Baylor College of Medicine GI clinics for diarrhea and other, and see one of my partner. They will do the fecal elastase. If it is normal, then that's fine. If it is low, they will refer them to the advanced group, me and my partner, and we'll do an EUS. And here we looked at the patient in 1 year. We just looked at 40 patients who have low fecal elastase and have EUS. And what we find that just by using fecal elastase for screening and doing an endoscopic ultrasound, in this 40 patient, the majority have either definite or indeterminate chronic pancreatitis. Some did have pancreatic mass, and actually 2 patients out of 40 had pancreatic cancer, which is totally different topic we can discuss later on, that patients with pancreatic cancer can present early on with pancreatic insufficiency. But then something interesting stood out. 22% of the patient had fatty pancreas. So when this was published, it's published 2019, but actually this data was running in 2017. When I saw that caught my attention. Why 22% of this patient have fatty pancreas? So start looking at all our patients with fatty pancreas. We knew about fatty pancreas from before. I would always write it in my report, but I wouldn't associate it with the exocrine pancreatic insufficiency, because the API has an implication. This patient will come to your clinic saying, doctor, I have bloating, I have diarrhea, I have all these symptoms, and a lot of time attributed to irritable bowel syndrome, not to pancreatic insufficiency. So we looked at 2 groups. One of them control, who just came for diarrhea and had fecal elastase, and others who also have fecal elastase, but they have a fatty pancreas. And if we look here, and the one who have diarrhea, only diarrhea and no problem with the pancreas, 6% of them have low fecal elastase and API, but 47% of the cases, half of our cohort of fatty pancreas has pancreatic insufficiency, which told us that actually patients with fatty pancreas would have diarrhea, bloating, and all the symptoms because they are not secreting enough enzymes and because they're not digesting their food. And later on, bacteria would work in it. They would get bacterial overgrowth. So they could be treated with pancreatic enzymes and courses for bacterial overgrowth like rifaximin. We did a multivariate analysis because who knows, maybe these cases have high API status because of other factors. So we looked at maybe they have higher chronic pancreatitis, and with multivariate analysis, fatty pancreas alone, without any relationship to chronic pancreatitis, was a predictor of API status. So although some patients with fatty pancreas could have chronic pancreatitis later on, and although this is possible, fatty pancreas without chronic pancreatitis caused exocrine pancreatic insufficiency. This is another study here about the prevalence of fatty pancreas in EUS. Since it is that common, how often we see it. So it's a nice study from Iran and published in 2019. They looked at 228 consecutive patients who just came for EUS exam. So every patient comes to the hospital during 6 months. They try to see if they have fatty pancreas or not. On an endoscopic ultrasound, they found that the prevalence of fatty pancreas is 25%. They also took blood tests before, and it's a beautiful study because I like how they did it prospective manner, they collected blood sample for everyone healthy versus fatty pancreas patient, and they found that patient with fatty pancreas have a higher level of uric acid, has history of ischemic heart disease, higher level of hyperlipidemia, higher level of fatty liver, and actually have also aortic intimal thickness is increased, as we see also in fatty liver, which mean that fatty pancreas is part of the metabolic syndrome. So someone would tell me, well, this data is exaggerated. You're talking about endosonographer who are looking at the pancreas, and if the patient coming for a EUS exam, he must have something related to his pancreas, and maybe that's why, although that's not entirely true because we do EUS for other reasons. But if we look at this beautiful study done by Chinese University of Hong Kong in 2014, it was published in the American Journal of Gastro, the Red Journal, and basically they used fat water MRI to quantify the amount of fat in the pancreas, because normally fat will be in the pancreas, but the question is how much fat is too much. So in ultrasound, we know it because it has this diffuse echogenicity. So I can say in a binary manner, yes or no, there is fatty pancreas or not. But there is a bigger important question, how much fat in the pancreas? So the only way to quantify fat in the pancreas is using this technology, fat water MRI with proton magnetic resonance spectroscopy. And it's basically a technique, and this technique, you really have to talk to your radiologist to be able to do it. And I have been working now with our radiologists at Bader to do it, but it's not that easy. And basically they get a screening of 685 patient healthy volunteer. They also looked at alcoholic and other and find that 10% of fat in the pancreas is the upper limit of normal. You and I, everyone should have in their pancreas between 2 to 4%, up to 10% is fine. Beyond 10%, that's considered cut off for maximum fat in the pancreas. Using that value, they discovered that in patients between age 40 to 49, 16% had fatty pancreas, 18% has fatty pancreas. And if you get older than 60, the chance become 26%, which is not that different from the previous study in Iran here, which is a totally different population in Middle East, which has around 25% prevalence of fatty pancreas in EUS. So this much higher prevalence that any one of us would think of. And when we say 16 to 20% of our population, and I don't want to extrapolate here, but this study was done in Hong Kong. And if you go to Hong Kong, we was not as obese as we see in Texas in the United States. I would tell you the prevalence in my population is much higher than that because of the obesity. So the same university, the Chinese University of Hong Kong, they did another excellent study, and I consider it so far the best study done for fatty pancreas. They started with patient 2008 and 2009, who they had known fatty pancreas using the same technology I told you about, and they are the one who perfected it. They looked at them for 11 years. They quantified their fat based on this fat water MRI, and as you can see here, fatty pancreas, they looked at fatty pancreas and fatty liver, and they found that fatty pancreas is an independent marker for development of diabetes, not fatty liver, fatty pancreas alone. So they found that fatty liver does not lead to that, but fatty pancreas lead to diabetes. And actually the percentage, each percentage rise of pancreatic fat, let's say from 10% to 11%, associated with increased risk of 7%. The study is just recently coming, and it is actually published. It will be published in September in CGH. So as we can see here, this is one of the strong evidence of diabetes development after fatty pancreas, 11 years follow-up. So here is a serological diagnosis of fatty pancreas. So now, somebody like me and Dr. Okasha and others who are attendee here who are EUS lovers, we do EUS, but you cannot do EUS in every patient. And honestly, we shouldn't advocate for doing that. It is too much cost to the system. So we have to have a way to diagnose this patient with non-invasive serological tests, or maybe once we diagnose them, we can take them to the next level. So here is a nice test called lipocalin-2, and lipocalin-2 is secreted in case of stress from pressure from the adipocyte. And they looked here at lipocalin-2 in patients with fatty pancreas and fatty liver, and they found that it is really significantly associated with patients with fatty pancreas, not fatty liver. That would be a nice marker that we can consider that would be only for fatty pancreas, but definitely looking for a marker of fatty pancreas is the next step to diagnose this patient. So I will tell you a little bit about some of my personal observation. I showed you a lot of data, but right now I'll tell you my opinion. My opinion and things I noticed that fatty pancreas is reversible. So I have some of my patients who I advise them to have diet and exercise, and they lose between 15 to 30 pounds, which is around maybe 10 kilo, the fatty pancreas disappear. And also when the fatty pancreas disappear, the API status will also resolve. Why is that? Because we are talking now about not fat necrosis or fatty replacement of the pancreas. We're talking about that the fat is causing pressure over the pancreas, and that's why the acids are not secreting enzymes, but the acids are still there. And then once the fat removed or decreased, then the acid goes back to work normally. I don't really have enough data to see that, but I saw at least 5 patients who really did very well by losing weight, and they were in pancreatic enzymes and did not require it anymore. I also noticed this progression from fatty pancreas to chronic pancreatitis, and we also show it in some of our study, but it's sometimes very hard because you have to be focused, because once you have chronic pancreatitis, it changes, it is more hypoechoic, and it becomes harder to diagnose it. And fatty pancreas, in addition to this diffuse echogenicity, sometimes it has the humps if you have too much fatty pancreas. So you have to just get used to read the in between the lining. There's a background of fatty pancreas, but there's also chronic pancreatitis. Then I have this clinic for screening for pancreatic cancer, and basically we screen patient with the ATM gene, BRCA1, BRCA2, and all of them, they mainly have have no problem with pancreas. They just have family history of pancreatic problem, or they have increased risk of pancreatic cancer. And I'm finding fatty pancreas in the subgroup of patient too, and most of them, by the way, are not obese, which tells me that obesity is not the oldest story, and there's also some relationship between fatty pancreas and cancer development. That's another area of research that I think we should look at. The study by Rashid Liu from Chinese University of Hong Kong, when they looked for 11 years, none of their patients developed pancreatic cancer. They did develop diabetes and chronic pancreatitis, but not pancreatic cancer. So we should also, I don't know how much of this patient will develop pancreatic cancer, but it's something we should look at. So what's our protocol once you diagnose patient with fatty pancreas? What we are going to do with them? You want to assess their API symptoms, ask about diarrhea, bloating, statins as stool, and then I order fecal elastase. If they don't have pancreatic insufficiency, I order fecal elastase once a year. If it comes low one time, then I don't order it. If they lose weight, we'll repeat it again, because we know that this process is dynamic. Unlike chronic pancreatitis, once you have a permanent damage in the pancreas and you have low fecal elastase, there's no point of repeating it. But in this subset of patient, I believe there's a point of repeating it. I also order hemoglobin A1C for them every 6 months for development of diabetes. I do EUS every 3 years in this patient. There's no recommendation about that, but I do it as part of my screening for chronic pancreatitis. I talk to them about the risk of fatty pancreas going to chronic pancreatitis. I offer them this type of screening, and I also explain to them there's not enough data to support that, but that's my own protocol. I also encourage diet and exercise, particularly if the patient already have pancreatic insufficiency, because I tell them once you reach this level, you have one or two conditions. Either you have chronic pancreatitis with fatty pancreas, or you have too much fat that your acids are stressed. Please lose weight. Let's see what will happen. And also there's a possibility that the use of antioxidant could help to prevent the progression of fatty pancreas to chronic pancreatitis. This is also another area of research that I'm thinking of. So I give you now a lot of ideas about research in this area. So in conclusion, fatty pancreas is more common than what we think it is. The implication of fatty pancreas is not yet fully understood. Fatty pancreas can lead to exocrine pancreatic insufficiency and all of its associated symptoms. So remember to treat this patient. They might need pancreatic enzymes. And non-invasive testing for the diagnosis and follow-up of fatty pancreas patients is needed. Thank you. And we'll open the discussion now for any question.
thank you very much, Mohammed Osman, for this really very valuable lecture. It answered most of the questions which I'm preparing to ask you, except only 2 questions. But first, I'd like to, any question from the floor? Yes, Professor Mazen Naga.
Thank you very much for the nice lecture. Now we are doing celiac screening for patients with IBS. Should we add fecal elastase also to patients with IBS?
Yes. So Dr. Mazen Naga, that's exactly, we did a study about that, and it will be published very soon about 200 patients, 140 patients who came to our clinic with IBS symptoms, and we were ruling celiac disease and also doing fecal elastase, and we find the prevalence was around 60%. So 6 out of 100 patients did have pancreatic insufficiency and responded to pancreatic enzymes. So I actually always encourage adding fecal elastase to the other serologists who are doing. And sometimes to people, like we have an IBD clinic, so we take one sample of the patient if they have diarrhea, and we do fecal elastase and fecal calprotectin. And that's a protocol we're doing between the pancreas and IBD clinic. And I feel like it really increased the yield of diagnosing this patient early, but also diagnosing pancreatic cancer, as we show that 2 patients came from this protocol of low fecal elastase that they had an early pancreatic masses that were not seen. So yes, Dr. Naga encouraged doing fecal elastase.
Any questions? Any other questions? I have only 2 questions. Really, you answered most of the questions. If we do a research in other way, in patients with referred for cancer pancreas, whether head, body, and tail, we do endoscopic ultrasound, diagnose it as cancer for sure by even FNA. We can look for if the patient has fatty pancreas by looking to the healthy parts. If it is cancer head, we are looking to the body and tail, and vice versa. So we can determine the percent of fatty pancreas in patients with cancer pancreas. And then other patients who are coming for any reason else, whether submucosal tumor or something with special something, we look to the pancreas to assess the fatty pancreas in the general population and compare with each other. Do you agree about this very simple protocol, or you have concerns about that? So we can go in that way because it is much easier than doing many sophisticated follow-ups and the long period of follow-ups. I noticed will not be ideal, but can it be achieved? Do you have concerns about this?
So for patients with pancreatic cancer, there is some fatty replacements that will happen. And in this situation, that MD Anderson, they did a study, they looked at the specimen of Whipple, and they found there is always fat surrounding the pancreatic tumor, but this coming from the inflammation. So we learned that also as a part of the inflammatory reaction, the adipocyte will form. So the question here would be, is the fat that we see in patients with pancreatic cancer is a result of the cancer being there and the fat formed, or the other way around, that the fat came first, then the cancer came? So far, we don't have evidence that fatty pancreas per se will lead to pancreatic cancer, at least based on the 11 years the study was done. But we know that patients with pancreatic cancer will do have fat around the pancreas. The other part is that whether in other patients who are coming for usual screening, should we screen them for fatty pancreas? I totally agree. And I know it is always a good habit, if we even doing EUS for submucosal nodule, to take a look at the pancreas. I mean, all of us as a EUS or a pancreas lover, we should look at the pancreas, and sometimes we discover things that's totally unrelated. A lot of time I discover chronic pancreatitis for patient referred for totally different reason, like antral nodule or esophageal nodule, and they do have chronic pancreatitis. So yes, I think all EUS examination should include examination of the pancreas. I'm looking for that.
Okay, my last question is about what about focal fat changes of the pancreas, like in the liver? Sometimes we find an area of hyperechoic area, angulated margin, looking like that. We found it in the liver, the famous fatty focal changes of the liver. We found it in the pancreas. And in many instances, we can differentiate it from malignancy. Do you consider focal fat pancreas as generalized form of pancreas? Or what your opinion about these focal fatty changes? Can we consider it fatty pancreas with the same pathogenesis and same pathology?
Yes, so I have a theory about it, but I don't have evidence. And I can tell you my opinion, but that's not based on scientific facts. Because what I'm seeing and noticing that it starts first in the head of the pancreas. I feel like fatty pancreas goes through 3 stages. First, it starts as a focal, and sometimes that would be in the tail. We find that the tail is hyperechoic and the rest is fine. And sometimes it starts in the head. And then the next stage, you have this diffuse echogenicity everywhere in the pancreas. And then you get to an interesting stage that there's too much fat that you see almost like this humps, something like looks like a cotton appearance, like white fluffs. And this white fluffs, the border of the pancreas, instead of being normal, the border of the pancreas start to get irregular, and I consider that the third stage. So I feel that the focal area is the beginning of the fatty pancreas. The question, is it progressing or not? Because I'm doing a study about that. I'm looking at all my EUSs and seeing the progress of the fatty pancreas, especially the one that started with a focal fatty pancreas. And I feel they start as focal and they progress to become diffuse.
Yes, very interesting. Now we are just on time. Thank you very much for this very, very valuable lecture. And I think the meeting is recorded. And we, of course, will refer for sure for this valuable lecture in our way to searching or studying the new issue of fatty pancreas. Thank you very much, Professor Mohammed Osman. It is always a pleasure to discuss with you scientific issues, and we have the pleasure and honor always to see you anytime and anywhere. Thank you very much. Now we are coming to the last lecture in this session. Professor Kazuhara is with us.
Yes, hello.
Yes, hello. How are you?
Can you hear me? Yes, I'm fine.
Yes, I am hearing you. We are all here greeting you, and Dr. Muaz is with us now, and we are very, very anxious and very, very interesting to hear from you your opinion or your debate about the very important issue in the endoscopic ultrasound and the pancreatology, which is pancreatic cysts, a Japanese point of view. Thank you.
Yes. Thank you for Chairman. Thank you for Dr. Kasha and Dr. Erusel. Thank you for inviting me to such a wonderful meeting. It's my great honor to give a lecture. At first, I'd like to introduce myself. My name is Kazuhara. My institute is Aichi Cancer Center. Nagoya City is my hometown. Nagoya Castle, Legoland, Toyota Museum are shown in this picture. It's a beautiful place through the year. If you come to Japan, please visit Nagoya City. This picture shows our members. 12 doctors belong to pancreatic team. Young trainees visit our center to run interventional EUS procedure. We are also clinical oncologists, so we give a chemotherapy for the patient. This is our endoscopic room. Many foreign students visit our center to run EUS intervention. In this picture, Dr. Moraz performed EUS-BD. He came from Egypt. Now he is learning interventional EUS procedure, and he can get Japanese PhD in our research center. Today's my topic is pancreatic cyst, a Japanese point of view. Generally, Japanese doctor emphasis imaging diagnosis like gastrointestinal early cancers. EUS FNA is not recommended for cystic lesion because there is a possibility of tumor seeding by leakage. So if EUS FNA is not necessary, we don't recommend puncture the cystic lesions. Sensitivity of cytology is low, and cystic fluid analysis give not so much information. In the pancreatic cyst, 70% is neoplastic cyst, mainly IPMN. IPMN is a very common disease in Japan. Now we follow more than 800 IPMN patients in our center. It's sometimes difficult to diagnose the unusual cystic tumor by imaging only. In this situation, we perform EUS FNA for unusual cystic tumors. This is a flowchart to diagnose the cystic tumors. The most important point is appearance, multilocular or unilocular, grape-like or orange-like, solid or not, pocket duct dilation or not. These findings is the most important for imaging diagnosis. Multilocular, grape-like, and MPD communications are typical findings of IPMN. IPMN is a very common disease in Japan, so diagnosis of IPMN is not so difficult for endosonographers. IPMN classify three types: main duct type, branch duct type, and mixed type. In Japan, IPMN is not so rare tumor, so IPMN is usually detected by ultrasound of annual health check. How about serous cystic neoplasm? Honeycomb, microcyst, and macrocyst mixed. Central scar and classifications are typical findings of serous cyst neoplasm. Serous cyst sometimes looks like IPMN or PNET, so diagnosis of serous is sometimes complicated. This picture is a serous cyst neoplasm. Microcyst and macrocyst are mixed. A little bit high echoic tumor, hypervascular, MRI T2 high signal are typical findings. EUS FNA is useful to diagnose the serous cyst. After pathological diagnosis, we don't need a close follow-up. Annual health check is enough. So we suspect the serous cyst, we recommend EUS FNB because we don't need close follow-up after diagnosis. It's very good information for patient and us. SPN, PNN are degenerative tumors. It's very difficult to diagnose these tumors only by images. These tumors are very similar appearance sometimes. Can you diagnose these tumors? Under EUS, solid part and cystic part are mixed in all tumors. CT images are different findings. However, it's still difficult to differentiate these tumors. Finally, EUS-guided tissue acquisition is recommended. SPN is an indication for partial resection. Leg doesn't need operation. PNN needs a regular operation and lymph node resection. So, different diagnosis, different treatment. Diagnosis of typical MCN is not so difficult. Cystic cyst or orange-like appearance is useful findings to diagnose. MCN is sometimes very similar with oligocystic serous cyst neoplasm or pseudocyst. In this situation, we recommend cystic fluid analysis. Cystic fluid analysis is useful to differentiate mucinous or non-mucinous. However, many Japanese surgeons doesn't like the punctured cyst because of leakage, so Japanese surgeons recommend laparoscopic surgery at first. They are very skillful surgeons. Distal pancreatectomy is a very safe procedure for patient. Patient also choose surgical resection than EUS-FNA. Diagnosis is the first. Next step is management. I already mentioned diagnosis of IPMN is usually not so difficult. However, management is a little bit complicated. International consensus guideline is very useful for management of IPMN. Basically, we follow this guideline. If we detect high-risk stigmata, we consider the surgery. OJ is usually seen in advanced tumor. Findings of enhancing nodule more than 5 mm and MPD dilation more than 10 mm. These findings are early IPMC findings. Cancer possibility in this stage is nearly 50% according to our data. So half is CIS, half is adenoma. This is the best timing to consider surgery. How about worrisome features? If we detect more than 2 worrisome features, we consider surgery. However, if 1 or less, we follow the patient using EUS and MRI sequentially every 6 months. Of course, if patient are old age, we don't recommend surgery easily. This case is a big cyst. However, there are no more worrisome features in this IPMN. Only 1 worrisome feature is seen in this patient. In this situation, the IPMN is usually benign. We follow every 6 months. We can see the big cyst and the second cyst wall. There are 2 worrisome features in this IPMN. Of course, this IPMN is not so high risk in this situation. However, we consider operation or close follow-up. How about ERCP and or EUS-FNA for IPMN? If we follow the patient every 6 months, we don't miss the timing of surgery because IPMN is a slow-growing tumor. Imaging diagnosis is usually enough to decide the management. Pancreatic juice cytology is low sensitivity, nearly 30%, so we concern complication by ERCP and EUS-FNA. Mortality of pancreatoduodenectomy is less than 0.5% in Japan. Basically, surgery is a safe treatment. So if we suspect the malignant changes, we recommend operation first. IPMN is also high risk of the PDAC. We can see the PDAC, no relation with IPMN size. IPMN is a very slow growing tumor and not so aggressive tumor. However, PDAC is very rapid growth and aggressive tumor. So we should care the PDAC more than IPMN. This is an educational case of IPMN. This is the first case. This case is a big IPMN. Cyst size is more than 3 cm. We can detect only 1 worrisome feature in this patient. We cannot detect malignant findings, so we discuss the management with the patient. Finally, we follow the patient. After 5 years, IPMN is not so changed, but we could detect MPD stenosis by EUS. We suspected the early PDAC. We recommended surgery. Finally, we could diagnose the small PDAC with IPMN. IPMN is big, but IPMN is not so changed and not malignant. PDAC is small, just 6 mm, however, very aggressive, because lung metastasis appeared after 3 years. Second, educational case is also big IPMN. In this MRI, we cannot see the malignant findings, just big cyst. I show you the video. This is IPMN. This IPMN is big, but wall is not so thick, and we cannot see the mural nodule. Can you see this is IPMN? But around here, a little bit low echo. We can detect the low echo tumor just outside of the IPMN. We can see the PDAC just outside of the IPMN. IPMN is not malignant. Under EUS examination, sometimes we focus only IPMN, and sometimes we focus only inside the cyst. However, PDAC will appear outside of the cyst, so we should take care outside of the cyst much more than inside. Third case is a small branch duct IPMN. No high-risk stigmata, no worrisome features. Under EUS, we can detect the small, low echoic area just outside of the cyst. We recommended surgery. Pathological finding is 5 mm PDAC. PDAC located just outside the cyst. The patient survived more than 5 years. So, pay attention not only inside the cyst, sometimes just outside the cyst. This is very important. These tables are incidence of PDAC concomitant with IPMN from Japanese paper. The frequency of PDAC is around from 2.5 to 8.3%. Average is nearly 5%. So we have to care the PDAC for IPMN patient. IPMC is slow growing, but PDAC is a so rapid growth, so we should care the PDAC. This is our follow-up plan for IPMN patient. At first, EUS, CAT scan, MRI are recommended. During follow-up, EUS and MRCP sequentially every 6 months. CT scan is not necessary because of radiation exposure. Now we follow more than 800 patients. No patient died caused by IPMC in this follow-up system. 80% of PDAC we detected in the system were stage 1 cancers. Finally, I'd like to mention about simple cyst or retention cyst. In fact, these cysts are clinically very important. These cysts are also risk of PDAC. Non-neoplastic cyst is also risk of PDAC. Panning lesions cause the pancreatic cyst, sometimes cause MPD stenosis. Finally, panning 1 lesion will become invasive cancer after 10 years or more. So we should follow up the pancreatic cyst, even small cyst, even simple cyst. We want to detect panning 3 lesion because 5-year survival is nearly 100%. Panning 3 is a carcinoma in situ. So how to detect the panning 3 lesions? Now, not yet discovered. Recent Japanese trend is repeated pancreatic juice cytosis using nasal pancreatic donor tube. Nasal pancreatic tube is placed for 1 night. Pancreatic juice cytosis is applied for 6 times in half day. Some Japanese centers reported usefulness of nasal pancreatic donor tube. However, I don't like these techniques because of risk of the pancreatitis and uncomfortable for patient. And my result of cytologies are very bad. Finally, we should follow the small cyst, even small cyst, every 6 months. Fortunately, Japanese people have a serious personality, so they can go to hospital regularly. This is a summary of Japanese point of view. First, for diagnosis and management of IPMN, EUS FNA is usually not necessary. For diagnosis and management of degenerative tumors, EUS FNA is necessary. IPMN, even small cysts, are high risk of PDAC, so we recommend follow-up every 6 months to detect early PDAC, not IPMC. This is my final slide. Thank you for your kind attention. Thank you for inviting.
Thank you very much, Professor Kazuhara. Very clear messages regarding the Japanese point of view in management of pancreatic cysts. Now we have 5 minutes for discussion. Any questions from the floor? I have a question for you. You mentioned that regarding serous cystadenoma, you prefer to do FNA. You do EUS FNA in serous cystadenoma in all cases, or when you do FNA, because here in usual practice, when we have a characteristic picture of microcystic serous cystadenoma with honeycombing, so we didn't do FNA. But in the last months, I had a case of micro and macro cystic serous cystadenoma, a large multiloculated cyst, some which are small with honeycombing and some which are large. And after EUS FNA, the final diagnosis was mucinous cystic neoplasm. And another case in the last months of classic honeycombing of microcystic serous cystadenoma, there was a large solid part about 1.5 to 2 centimeters. And by doing FNA, the final diagnosis was adenocarcinoma and mostly on top of serous cystic neoplasm. So the most probable diagnosis is serous cystadenocarcinoma and not cystadenoma. So my question to you, when to do FNA in serous cystic neoplasm?
Yes, this is a very good question. So now in Japan, imaging diagnosis is most important, we believe. So at first, we suspect serous cystadenoma. We puncture the cyst because we believe this is a serous. But sometimes serous cyst and adenocarcinoma, IPMN and MCN, sometimes very similar. But serous is only benign tumor. IPMN, MCN, adenocarcinoma is malignant. So quite different management. So first, I suspect the serous, I puncture. This is my answer.
Even if it is a classic microcystic serous cystadenoma, without any solid parts, and all the villi are small like honeycombing, you prefer to do FNA?
Yes. Because if I diagnose a serous, this is benign. Puncture is safe.
Okay.
So at first, puncture is okay. This is Japanese opinion.
Okay, another question regarding serous cystadenoma. In asymptomatic cases without symptoms, when to refer and you will do, of course, FNA as you just mentioned. And the FNA is very nice, it is benign looking. When to refer the patient for surgery? Large cysts, some of the guidelines mentioning that serous cyst adenoma more than 4 centimeters, better to refer to surgery. And some guidelines are saying that cysts more than 7 centimeters are better to refer to surgery. So reference to the surgery depends on the size of the tumor, or the results of FNA.
Yes. So now in Japan, no relation of the size. If patient has a symptom, we refer the operation. But no symptom, no need operation. No relation of the size. This is Japanese opinion.
If it is a large one, more than 10 meters or something like that?
Yeah, of course. More than 6, no symptom, no need operation.
Yes, okay. My second question is regarding IPMN. You mentioned in a clear message that you do not prefer to do FNA in IPMN. But sometimes we find worrisome features, like cyst more than 3 centimeters, and no sure evidence that it is IPMN. It may be a cyst, other cyst, non-IPMN. It's very difficult to differentiate depending only on the EUS features. We found it very frequently, and I am in a mess to take FNA or not to take FNA. If you leave it, it may be not IPMN and another cyst, and you just mentioned that there is some instance of adenocarcinoma. What to do in this borderline cases? What you follow up, or FNA in the presence of worrisome features?
Yes, this is a very nice question. Maybe Japanese opinion is a little bit different from Egypt. So at first, surgery is very safe. Surgical skill is very good. So surgery is very safe. So surgery is not bad for benign tumor.
Yes, but thank you very much. You have very clear messages, and we thank you very much for these clear messages. But in other countries, the morbidity and mortality of surgery, pancreatic surgery, may be somewhat a little bit or markedly higher. So what is applied to in Japan may not apply in other countries. Do you agree with me?
Yes, of course. But the IPMN diagnosis is not so difficult because much mucinous MPD dilation, branch duct dilation, much mucinous missing. So IPMN diagnosis is not so difficult. But sometimes another cystic tumor is difficult to diagnose. Can you see? So if you diagnose IPMN, we can diagnose malignant or not.
Yes, okay.
Even that we can suspect this IPMN is malignant. So if you suspect the malignant IPMN, you don't need puncture. Operation first.
Just send for surgery.
Yes. If you suspect malignant.
Yeah. Yes, thank you very much. Thank you for that. Yes, there is a question from Dr. Muaz. Dr. Muaz.
Dr. Hara, can you hear me?
Yeah. I want to see you.
Thank you very much. Great talk. Sorry, my account is in your name because I received the same link for you for Zoom. So it's I entered Zoom through your name. So just I want to clarify a point related to surgical procedure for suspicious pancreatic cyst in the pancreatic body. It is I clearly know that it is quite different in Japan than Egypt. When to recommend middle resection or mid pancreatectomy for suspicious cystic lesion? I mean, suspicious IBMN or MCN or SPN located in the body or proximal body. So from your experience, I just you to clarify the possibility and the efficacy of medial pancreatectomy to save the pancreas.
Yes, so for example, IPMN. So IPMN, high-risk schemata, but not so malignant finding. This is a very early IPMC. So early IPMC is no metastasis. So if tumor located in the body, we recommend a middle transverse resection of the pancreas because the patient keeps the pancreas parenchyma too much. SPM, usually benign tumor. Of course, very rare cases malignant. So SPM, usually we recommend transverse resection.
Yes.
Yeah. And the PNET, less than 2 cm in the body, we recommend transverse resection. We want to keep the pancreas. Yeah. This is my answer.
Yeah.
Okay, thank you very much, Professor Hara. We are very happy and very pleased and honored to have you in this Congress and to hear this very valuable lecture with clear messages. Thank you very much. Now we are coming to the end of this session, exactly in time. And we will continue after only 10 minutes. Only 10 minutes. There will be a break. You can eat something. Even you can continue eating in the second session. But we should start the second session in 4:15. 4:15 بالضبط إن شاء الله نبقى هنا بإذن الله إن شاء الله. شكرا.
So we'll start the second session. It's a great honor and pleasure to introduce Professor Malay Sharma, consultant in gastroenterology and intervention endoscopy, Merit, India. Professor Malay Sharma, no need further introduction, one of the eminent professor of EUS, have many publications in the field of EUS. Please, Dr. Malay.
Hello, am I audible?
Yes, we can hear you.
Okay. So I start my topic, image optimization during EUS, and we have to talk what is infrasound and ultrasound. Infrasound is an image which is basically on the lower side of ultrasound, and we are talking of ultrasound which speaks from 20 kilohertz to 40 kilohertz. So EUS is done by a pulse transducer which transmits and receives sound. Sound goes in, and for 1% of time it is speaking, and 99% of the time it is listening to your voice. So once we see what is going on, in pulse ultrasound works on the principle of echo-ranging. What is echo-ranging? That the sound will go. For example, in this screen, you are seeing on the left side that the sound is going for a distance of about 2 centimeters. On this screen, the sound is going for a distance of about 20 centimeters. So the distance is called echo-ranging. And we are seeing now the echo-ranging. For example, in this case, we see a distance of 5 centimeters. And in this case, there is a distance of 20 centimeters. So the pulse repetition frequency
is what decides how many times the sound waves are going to hit the far side of the screen and come back. For example, in this case, the distance is 10 centimeter. The speed of sound is 1500 meter into 100. And in this case, the PRF is 15 kilohertz. Whereas in this case, distance is much more and the PRF is much less. So why we use 2 centimeter or 20 centimeter? In this case, for example, there is no point in wasting energy. Whatever we want to see in this screen are within 2 centimeter distance. So I will stick to 2 centimeter distance and not 20 centimeter distance. So sound is sent by elements. When we see a transducer, these are the elements which are fitted in the screen. And these elements send one by one. The sound waves are transmitted from one element to another. And these elements keep on shifting from one side of the screen to another side of the screen, as you can see by this figure, that the arrow moves from this side to this side. And the elements are spaced. In a transducer, you can see these elements are spaced at around 0.5 degree centimeter between two elements. And for a 120 degree transducer, there are about 240 elements. And these elements are different in different kind of company, different type of transducer. The sound waves, when they come out like a torch which focuses, they come and they focus. And they focus and then they diverge. So the zone is divided into near zone and a far zone. And this is the focus. Sound waves are best seen at a focus, where we can see the focus. So imaging is all about resolution, and there are 3 times spatial. But this is spatial resolution is high, this is low. Temporal resolution is about time, and last is about the contrast resolution. We'll talk of contrast resolution. These are the 3 resolutions we will talk of. Axial resolution, spatial resolution of 3 types, axial, lateral, and azimuth. This is axial. Along sound waves along this axis, and we can see these 2 points as separate point, or these 2 points as one point as the blood point. Lateral is we can see side by side. You can see this point or these 2 points as separate points, and this is lateral resolution. The azimuthal resolution is done practice. Generally, it doesn't come in practice because it depends on the transducer construction. Temporal resolution depends on the sound waves which proceed at a speed of 1540 meters per second and is calculated the velocity of sound is equal to frame depth into frame rate into frame width. This is frame width, this is frame depth, and this is the frame rate which is displayed on the screen on this side. This frame width, frame depth, frame rate, these are the 3 things that decide the, for example, in this case, the temporal resolution will depend on the depth. This is the depth, frame width, and frame rate. Here, the frame depth is only 2 centimeter. Here, the frame depth is 20 centimeter. Here, the frame width is 150 degree, 100 degree, and we have to zoom. Once we select the area, we can zoom it, and we can zoom for better resolution, because if you want better temporal. What happens if you are seeing a screen and then you zoom it after freezing? This is called a read zoom. But you actually zoom the zoom box while doing it and then zoom in. This is called right zoom. Right zoom is always advantageous compared to read zoom. So we have to understand the concept of contrast resolution, and we have to understand that this is image as pixels, pixels as bits, and bits has got number of shades, number of bits. So these are the shades. And if you have 2 bits, 4 shades, 4 bits, 16 shades, and if you have 8 bits, we have 256 shades, which is the number of shades that we see on the bar, on the displayed on the side of the screen on ultrasound. For example, CT has got a 10-bit image of 2024 shades. So these shades are important because you can see either so many shades or you can see less number of shades. If you see more shades or less shades, this is called dynamic range. And the dynamic range can be, in this screen, we are seeing more number of shades. You can see. And in this screen, we are seeing less number of shades. The dynamic range is less. So dynamic range is important if you want to see only black or only white, you see less dynamic range. If you want to see different characters of tissue, you want to have more dynamic range. For example, in this case, this is the range of shades that you see, and this is very white, this is black, and these are all shades in between display and an image. So when we try to see image optimization, we have to do color Doppler optimization, and this is the moving blood. The sound waves hit it, and they hit the moving ERPC, and they come back, and this is the echo of the returning wave. And this is the Doppler signal is created, and this Doppler signal depends on the velocity of the flow, the angle. So this is the angle between the sound waves angle and the velocity, and this is the angle. So if the angle is perpendicular, there will be no detection of flow. But if the angle is about 60 degrees to 45 degrees, there will be display. Some of the Doppler signal will be perceived by the Anderson cloud. So we have to define several. When you talk of color Doppler mapping, you have to define color Doppler box. You have to define the map, the limits, these things we will explain. Whenever we put in a space, this box appears on the screen, and this is a superimposed image because you see these are the lines, and within these lines, within this box that you see on the screen, this you will find that color box is superimposed on the beam mode. The color map, on the side of the screen you see a bar. The bar is from this point to this point. This shows the extreme yellow. This shows the extreme, means highest negative velocity as the lightest blue. And in between, this black bar means there is no velocity. For example, when we see this image from superior mesenteric vein and artery, we can see that these are the vein, this is artery. Blue means the flow is away from you. Red means the flow is towards you. And red means more velocity. This area has got more velocity, higher velocity. When you see the edges, the velocity is lower in the peripheral part of the, and this is more dark blue. The central part is light blue, like the higher velocity. Peripheral part has lower velocity. What is Nyquist limit? So whatever velocity we are seeing on a screen can be measured. And Nyquist limit is the uppermost velocity that you can measure. For example, this is zero flow, and this is the upper end of the Nyquist limit. This is the lower end of the Nyquist limit. But if you display the line, the bar, up or down, you can change that. In this case, the upper Nyquist limit of measurement is 60. The lower limit of this Nyquist measurement is 20. So explaining all this jargon, the velocity scale, PRF, what do we measure? When we measure Doppler shift, we have to see whether this scale that we are using for measuring the height of this man or this man, same, we are using small scale or a very big scale. If you are using a small scale of 6 inches to measure this height, this is inappropriate, too small. And if you are using a very big scale to measure the height of this person, again, this is again inappropriate. What is the principle? Principle is that you must select appropriate scale. If the veins which have low velocity use low scale of measurement, arteries has high velocity, use high scale of measurement. And if you use high scale of measurement, there is no measurement policy. But in arteries, if you see low scale of measurement, then you get a feature of aliasing, and that is what we will show. For example, in this case, aliasing is an error in measurement. For example, this is a scale. From here, this scale, we see in this part, the color is light red, similar to this. Here it is bright red, similar to this. But it has changed to bright blue because the velocity in this part of aorta is very high. And this is unable to measure this such a high velocity. That is why this color is changing. So you see such changes of color from one spectrum to all the way up. The same spectrum that you are seeing here, the same spectrum you are seeing here. And this change in color is called aliasing, very strange. So what do we do? In this case, we are measuring with the velocity of 21.9. What we need to do is we need to increase the velocity range, that is to measure this velocity. Last is we do duplex imaging and triplex imaging, and this is duplex and triplex. As soon as we apply pulse Doppler on this, the screen freezes, and this is called triplex imaging. An interesting thing that you see, is this aliasing? No, this is not aliasing, because in this place, the color is changing from bright red to dark blue, and in between this black box is seen that is similar to this black box, and in this part, this black box indicates that the color has changed from negative to positive color. In aliasing, you will never find a black spot. In aliasing, you will find a change from one bright color to another brightest color. And the change of light red to darkest red to darkest blue will indicate the change of direction. So here, this is aliasing. Here, this is change of direction. You see the graph has changed from one side to another. One extreme to another extreme change is aliasing, and one velocity direction to another change is change in velocity direction. So once we see this part, we see the increase in frequency, because in this case, what we are seeing, we are increasing the frequency. We are adjusting the focus. This is the focus. We zoom this focus, and then we do right zoom, because we have done this is the focus. Suppose we want to see, this is the area we want to see, then we will do the right zoom in this area. And this is the right zoom. When we see, we are imaging. And in this case, when we applied right zoom, we applied color Doppler, there is too much of gain, and we try to decrease the gain, because the gain has been decreased. Now we can see, this is right zoom, this is the biliary structure. The color gain is reduced, and you can see the imaging better. So keep leveling the structures as you do them, because this is important. As you record, for your understanding, you can see this is superior vein, portal vein, superior mesenteric vein. This is the pancreatic duct. This is the bile duct. It gives you a better impression, better idea of what is happening. So this is, while doing it, you should be able to do it, and it will improve your analysis, because you are also recording it. And once you have recorded it, you will be reviewing it later on, and you will be in a better frame of mind. So follow the structure. The basic principle of EUS is you must follow the structures as they are moving. Follow one structure, one at a time. Always you can see one structure, and you do, sometimes you can do continuous color Doppler endoscopic ultrasound, that is called CCD EUS. And image the same structures from multiple locations. For example, whether it's pancreatic duct, you can see from many locations, all the three locations. So B-mode imaging is adjust image depth, lowest frequency gain, identify vein or Doppler, see the axis, use single focal zone. For example, in this case, use highest zoom, don't lose area of impress. Use lowest frequency if you want to do B-mode imaging. Optimal Doppler frequency must be found. So optimal Doppler frequency can be high, optimal Doppler frequency must be low. But if you want to do good imaging, initial imaging, B-mode imaging must be lowest. Frequency improves axial resolution, but we must use highest frequency. In this case, the frequency has been changed to 10 megahertz. In this case, then we adjust the gain button. We have decreased the gain because there is something seen within the portal vein. We have decreased the gain. And gain can be of three types: B-mode gain, color Doppler gain, spectral gain. We have limited time, so we will not talk of spectral gain. Lateral resolution depends on focus, compound imaging, tissue harmonic imaging. This is focus. As I said, we are taking this the focus point. Suppose 5 speakers are speaking, and this is the mic. Then this singer has to speak in such a way that he speaks a little before this singer, and the sound will concentrate like all 5 speakers are coming to one point. So this is the concept of focus. The elements have to fire in such a way that all the sound waves concentrate on the focus to give the best image possible. Because this focus improves better lateral resolution. This is best focus. This focus, this is not before. This is improper. and this is improper. Near focus, far focus. Keep the focus at the area of object that you want to see. The lines are firing like this, they are crossing. The area of best resolution is where all these lines are combined and you do compound imaging to improve radial resolution. Tissue harmonic imaging, the sound waves, this is the sound wave of a normal beam, this is the sound wave of a harmonic beam. And this sound wave concentrates here and midfield has got maximum harmony. What is harmonic? The returning frequency is 2 times the frequency of ingoing frequency. So when you are doing higher frequency, this will have better resolution. You should use a tissue harmonic imaging if you want to improve lateral resolution. Tissue harmonic imaging improves axial resolution also, but it improves lateral resolution. You can see the line density. If all crystals are firing, this is better line density. Less crystals are firing, this is less line density. I already explained the color flow imaging a little bit. I will explain these 4 points in red shortly, that you then adjust the color flow angle, color flow width. You can change this box, position, side, move the box from left, right, smallest box, change in x-axis, change in y-axis, or change in xy axis. So position the box. The video shows how you can see this. I will go to the gain point. This is the gain point. In this case, the gain is too low and the gain is too high. To adjust the color gain, you must adjust the correct settings of the color gain. Adjust the velocity scale. The velocity scale in this case is seen, velocity scale is 21.9. Velocity scale is 2.28 centimeter. So this is very low velocity scale. This is okay velocity scale. This is very high velocity scale, 8,000. To adjust the velocity scale, as I have already told you, that the veins must be measured with low velocity and arteries must be measured with high velocity. Now this is point I already explained. This is aliasing? No, this is not aliasing. Ask yourself the question, because this is change of direction. And this again is change of direction from one part to another. Flow away, flow towards you. Always record, review, analyze, because in this case we are seeing that there is a mass around the stone. It is recorded, we review it, and then analyze. In this case, we are seeing a pancreatic duct, a bile duct, both going towards the papilla, and the duodenum is filled with water. On the side, this focus is at the right side, and this patient we are imaging by. And once this is another common bile duct, a mass within the common a mass within the gallbladder, and we have done zoomed it. This is high zoom. We are seeing the wall structures. We have done all appropriate focusing, and this is the view that you get after appropriate. So there are several videos I can show, but I believe my time is up. All I wanted was that the image optimization is of B mode imaging, image optimization, subsequently of color mode imaging, and then only you will be able to get from the screen what you want to get. So this is the last slide. In this case, we freeze and then we review, and this is the artifact that you see, and this artifact will disappear once you apply the tissue harmonic method. So to speak on such a complicated topic is difficult, but I have tried my best to explain what we need to do. And so I'm thankful to Dr. Osaka and thankful to Dr. Amr and all the faculty for inviting me to give this lecture.
Thank you, Dr. Mai, for this elegant lecture. I have any question? I have only one regarding, I was asking you about artifact. I need simple steps to overcoming this artifact. In clinical practice, we can facing some artifact. But what is simple steps to overcoming this artifact?
See, when you ask this question, it probably You don't realize that artifacts are always welcome also, because they're telling me a lot. So don't discard artifacts. Artifacts are useful. They are telling you a message. They are telling you something about how the sound waves are behaving inside our body, how the sound waves are diffracting, reflecting, refracting. So in this case, I showed you an image. So the presence of artifact, presence of reverberating artifact within the microlithiasis tells me that this is a case of microlithiasis. But it tells me this is a caustic shadow. I need to see the caustic shadow at low frequency. I need to see a caustic shadow at high frequency. So you don't need to decrease the artifact. You need to understand and analyze the artifact. You cannot decrease it. You don't need to. You need to understand. You need to see artifacts at low image. You need to see artifacts at high image, high frequency. You need to sometimes, for example, you want artifact. You do a EUS FNAC. You want the needle to produce as many artifacts because you want to improve the visibility of the needle. So what do? Use higher frequency. Don't use compound imaging. Remove compound imaging. Make it as black as possible. Then what do you do in the needle? Decrease the dynamic range. You see only black and white. And you want the needle to be artifact because you know what tissue are you going to FNAC. And you want the needle to be seen while going in. And you don't know while coming back. Because sometimes you don't want to miss the pathway to and fro of the
Okay, thank you, Professor Marai Sharma, for this very deep lecture in that very difficult issue. I have some practical, one or two practical points. Sometimes, or even always, I found an artifact, echogenic artifact in relation to the tip of the echo endoscope, and I noticed that it moves with moving of the elevator. When I move the elevator or the lever, the artifact moves with me, and this is in many instances are bothering me, especially during FNE, EUS FNE. What you do to avoid this artifact in relation to moving the elevator? It is about 2 centimeters. It's exactly at the field, and moving up and down with moving the elevator. What are you doing to avoid this?
Sorry, I couldn't get the question, and but what I will tell you is mainly artifact is the artifacts are of basically 3 types. One is propagation artifact, and you need to understand artifact. You don't reduce, you enhance artifact, sometimes you reduce artifact. You need to understand the artifact. In fact, I will probably share with you a video I have of EUS of artifacts, how to understand all the
any other question? Thank you very much.
Thank you, Dr. Marai, for this elegant lecture. Hoping to see you soon in Egypt, maybe next year.
I really look forward to meet you. Thank you very much.
Thank you.
Thank you. Thank you.
Now it's my pleasure to introduce my dear brother, Professor Muhammad Abdel Hafiz. He is a consultant of internal medicine and endoscopy, and now he is a director of the endoscopy department at Munich University. And we are proud of Muhammad because he is one of eminent Egyptian doctors abroad. He is going to talk to us about updates of management of peripancreatic fluid collection. Please, Dr. Muhammad.
Thank you very much, Dr. Mahmoud, for your introduction. It's my honor and pleasure to be among you, Professor Hussein, and the chairpersons, and all my dear professors and colleagues in Egypt. It's a real great honor always to be with you. Can you hear me well?
Yes, we hear you.
Okay, and can you see the presentation?
Yes.
Okay, so I will start now, not to waste the time, because I have only 20 minutes. I try to make it a concise presentation, but still I have some, many slides. That's why I will start quickly with them. So my topic today is endoscopic management, or updates of endoscopic management of peripancreatic fluid collections. Actually, there is not a lot of new things to talk about, rather than I will talk more about some theories and how to enhance our modalities or our planning to manage these fluid collections endoscopically. So at the beginning, I will talk about some basics regarding this disease. So etiology of peripancreatic fluid collection. We know that it's because of acute pancreatitis, which is in half of the cases are biliary. 30 to 50%, at least here in Europe, are because of alcohol. There are, of course, other etiologies like post-ERCP pancreatitis, trauma, pancreatic duct obstruction, idiopathic, and we have also some post-operative leakage, especially after pancreatic operations. So the pathophysiology, we have the acinar cells, which will get the insult or the damage because of the causative factor. That will cause activation of trypsinogen, which in turn will activate the other enzymes like lipase, like phospholipase, elastase, etc. These activated enzymes will do the damage. I'm talking now about the necrosis. So something like the lipase and phospholipase will cause the fat necrosis. Something like the elastase will cause the hemorrhage after the leakage. Of course, it's a systematic disease because of the cytokines, which will be released immediately after the occasion of the acute pancreatitis. So that's what happened, the natural history of the pancreatic fluid collections. We will have this acinar cell trauma. Actually, in most of the cases, we have an obstruction or mechanical pressure inside the pancreatic duct, which will lead someone to pancreatic duct disruption. And usually that will happen only on one side, because once the pancreatic duct is disrupted, we have pancreatic leakage, which means the pressure is released from the pancreatic duct. This fluid will be accumulated, which will be called acute peripancreatic fluid collection. That will resolve in 50% of the cases. In 2 to 4 weeks, the rest of the cases will the fluid collection will be encapsulated. We will have a capsule. If there is no either there will no necrosis inside if the enzymes are not activated, or there will be necrosis if the enzymes were activated. If the fluid is sterile, we will call it pancreatic pseudocyst. If it is infected, we will call it pancreatic abscess. If there is necrosis, either sterile or infected, we will call it walled-off necrosis or walled-off pancreatic necrosis. This is very important here, the possible extension routes of peripancreatic fluid collections. As I said, once the pancreatic duct disruption happened, the fluid will be released in the retroperitoneum usually, and will take, we can see these arrows, so the fluid will take these directions. It can take one direction, it can take multiple directions, but it is important to know that, as I said, usually it is pancreatic duct disruption and only one side. That means the fluid will be released and it will run by itself through different ways, but it is always connected, or it is I would say over 95% of the cases, the fluid collections will be connected because it is the path of the fluid, the pancreatic fluid. I will explain it much better later on with a good example. So if we will have necrosis, infection will develop in 70% of the cases, and if we don't treat them, mortality rate is 100%. The diagnosis, ultrasound, can be very useful, but it is not very accurate in such cases. CT scan is the standard modality. We can do MRI, endosonography. So by assessing all different modalities, we can have, or we can estimate the peripancreatic fluid collection, and we can have a good plan how and what to do. This is a picture of ultrasound. Actually, it is from Egypt 10 years ago or 12 years ago by Dr. Maha Saballah. This is a CT scan of peripancreatic fluid collection or pseudocyst. Endosonographic picture of pseudocyst. Endosonographic picture of the necrosis here. So we have the cyst here. It is encapsulated, and we have the necrosis inside. And to be honest, it's sometimes very difficult and tricky to say if there is a necrosis inside or not, because sometimes if there is a pus inside, it will look exactly like the necrosis, and sometimes we can't see the necrosis. So it is sometimes very difficult to estimate if there is necrosis inside or not. When to intervene, when to say, okay, we have to drain the patient. With asymptomatic fluid collections, it is still debatable. I would say the size can decide. If there is infection, if there is pain, if there is gastric outlet obstruction, biliary obstruction, or if the size is getting bigger and very dynamically, or if there is inability to thrive or clinical deterioration, then of course we have to intervene and to do something. Early versus delayed drainage is always a question. Usually it's better to wait at least 4 weeks. In some cases, you can wait just 2 weeks. It depends if you can see a capsule around the fluid collection or not, because it will protect you and protect the patient against perforation in the peritoneum. What are the treatment options? If it is a pseudocyst or abscess, which means only fluid inside the cyst, then drainage should be enough for such cases. In many studies in the literature, EUS guided drainage is superior to percutaneous drainage. There are other studies that show that both are equal. But from patient preference, of course, transluminal would always be better. How to treat? We need interventional EUS device. We need carbon dioxide. This is very important. Never do cystic drainage or necrosectomy with air, only with CO2. Of course, we need fluoroscopic guidance. And to puncture, we need 19G needle. We need cystotome. You can either use, how they call it, ring knife or a cystotome, 10 French. Guide wires, plus minus balloon. It depends if you use something like 6 or French cystotome, then you will need to dilate before you put 2 stents inside. If you use 10 French cystotome, it is enough to put 2 wires and 2 stents. And for drainage, either you will put double pigtail or nasobiliary drainage. Actually, nasobiliary, we don't use it anymore. It is we used in the past, but it doesn't have any advantage in comparison to double pigtail. So this is an example of pseudocyst. It is 12 centimeters. Here we can see the pancreas. This is the stomach. Endosonographically, it looks like this. Here's the collection. Here, under fluoroscopy, you can see the EUS endoscope. And we inject, usually, or always we aspirate first for microbiology. Then we inject contrast metal to have mapping of the lesion. Then we push the wire inside. We have to do like 2 loops inside the cavity to have a stable position. Then over the wire, we push our cystotome, the 10 French cystotome. It has the advantage to put 2 jaguars inside it. Then over the 2 wires, we will put 2 pigtails. 2 pigtails are minimum. If you will put 1, it will be occluded very quickly. If you have 2 or more, you have this siphon mechanism. Even if the stents get occluded, the fluid will come between them. And it looks like this in fluoroscopic image after the drainage. Now, if we'll have necrosis, drainage will never be enough. The standard therapy and the only therapy is debridement. And how we can debride it? Surgery, it is obsoleted, it is in the past. So I think nobody is doing surgical necrosectomy since 20 years now, because the mortality rate can reach up to 95%. You can do laparoscopic necrosectomy, and you can do videoscope-assisted retroperitoneal debridement. All is surgical options, or you can do endoscopic necrosectomy. Endoscopic necrosectomy is the best, and I'm not biased with this, but there's a big and strong evidence that endoscopic necrosectomy is the best option for such cases. We have this PANTA trial, And we have tension trial. In Panther, they compared minimal invasive step-up approach, delayed drain and debride, and in tension trial, this is the Dutch group, they compared endoscopic necrosectomy versus minimal invasive surgery, and endoscopic necrosectomy was superior regarding hospital stay, cost effectiveness, incidence of pancreatic fistulas, etc. How we do it? Usually you will need multiple sessions to achieve complete necrosis. It depends how big is the necrosis and the site of the necrosis. Usually you will need adequate balloon dilatation, something between 15 to 20 millimeters to be able to come from the stomach or from the duodenum inside the cavity. Forward viewing endoscope, after the dilatation, you will come with a forward viewing endoscope inside the cavity, and then you will start your necrosectomy or debridement using different accessories. Till this year, there was no official device for a necrosectomy, so we used snares, forceps, baskets. I did with my colleagues in Egypt a study with the hydrogen peroxide, which was very effective. And I think there is came last week in American Journal prospective comparative studies between with hydrogen peroxide and without. And hydrogen peroxide already showed that you can decrease the needed sessions. Again, CO2 is a must. Otherwise, you have a big risk of air embolism. And at the end, drainage, exactly like the pseudocyst. Here we can see after the drainage, we put a wire, we put over the wire a balloon, 20 millimeters. We inflate the balloon. And we come inside the cavity. And we can see here the necrosis. And we are debriding the necrosis with different accessories. At the end, you put a wire, and then over the wire, you insert multiple stents. Usually I insert 3 to 4 pigtails after I finish every session. And then we will continue in another session. This is our target, to reach something like this. This nice pink colored granulation tissue that bleeds easily in touch. This is healthy granulation tissue which will collapse with time and will adhere to each other. As a new option, we have hot axial stent, lumen opposing metal stents. It looks like this. I think every one of you already have seen it. This is an example here. This is endosonographic picture of or video of the walled-off pancreatic necrosis. We puncture directly with the hot axial stent, and when we are inside, we release the inner flange inside the cavity. We withdraw it back, and then we open it in the stomach. And with this method, we can drain the cavity within 3 to 5 minutes. Plus, we have advantage that now we have a constant opening to the cavity. Usually, you wait 1 to 2 days after you insert it, that it's completely expanded, or you can dilate it with a balloon. Then you come inside, as we can see here. It's a nice cavity. There is not a lot of necrosis. And we see here with the basket, we try to grasp the necrosis and throw it in the stomach. Of course, the biggest disadvantage with this stent is the cost. It costs 4,000 euros. I think something like 80,000 Egyptian pounds. So it is really very expensive. And there's another disadvantage because it's a metal stent at the end. You are limited with your movement inside the cavity. If you have a complicated cavity, sometimes I need to remove the stent to have more freedom to move inside the cavities, because sometimes if I need to go to with acute angle to the left or to the right, the stent will limit my move. And this is what's new. I was honored this year. This month, we got accepted paper in GI endoscopy in multi-center studies. We use this endorotua. I will show you a video to show you exactly how it works. So I think this is the first and the only official device for necrosectomy. Here's an example. Here is the cavity. After we put the axius, we are using here the endorotua. It sucks the necrosis through an opening, and inside this opening there is a rotating knife which is cutting the necrosis. Although I was part of this big collaboration assessing this device, I'm not a huge fan of it. I believe it is suitable for some necrosis. When it is liquid necrosis or very soft necrosis, it can be very suitable, but it is a little bit slow. And it is also a little bit expensive. So one endorotor costs like more than €1,000, I think, €1,100. I wanted to present some examples at the end, but because of the time, I will present only one case today of a complicated world of pancreatic necrosis. To summarize everything I talked about, why to understand the theory behind the fluid collection, and to know why the idea or the theory that you have one site pancreatic disruption, the fluid will flow in the retroperitoneum, and they are always connected. And also to emphasize that to assess the imaging before you start to plan is very, very important. So this is a 36-year-old male patient admitted to ICU with acute biliary pancreatitis. We did ERCP, we removed the stone, and we put a stent, but of course the necrosis or the inflammation already happened. 2 weeks after the admission, his CT scan looked like this. So let's have a look again. The stomach. Then we start here to see some free collection that's starting to encapsulate itself. And we can see here the fluid collection extends. It goes upwards to diaphragmatic area. It goes to the pelvis, to the left pelvis, onto the right pelvis. It's really huge. At this point, it was not really encapsulated, and the patient was critically ill. As we see here, this is a photo. Endosonographic, it looked like this. So, because the patient was critically ill, we decided to do the drainage, although it is only 2 weeks. So one of my colleagues did the drainage. He punctured here, did give some contrast metal, put the wire, and put 2 stents here, 2 pigtails. Of course, you can here see the problem. If we compare this small lesion to what we have seen, it is nothing. You drain nothing. And many people believe it is enough just to drain. No, you have to have in your mind always this map, how it looks like in the retroperitoneum. 4 weeks after the admission, which means 2 weeks after the drainage, the patient was not improving. Actually, he was getting worse. He was septic. They intubated him for a couple of days because he had respiratory failure. The fluid collection is now encapsulated. We can see here our stents. I will try to find the stents here. We can see here the problem. Here, this is our transgastric drainage. And the rest of the fluid collection, the huge rest is still there. Nothing happened. It goes till the right and left pelvis. 5 weeks, they waited, they gave him antibiotics, the clinical condition deteriorated, it became very critical, so they decided to put CT-guided drainage. Of course, it is always critical after you put one drainage or endoscopic drainage and it doesn't succeed. Many colleagues in different departments will be they are doubting if this endoscopy can succeed. So they will start to discuss CT drainage, they will start to discuss surgery, and that's exactly what they did. They put here on the left side 2 CT drainages, and on the right side here another drainage. So he received 3 drainages. 8 weeks from admission or after the admission, patient can be transferred to normal ward. He was hemodynamically stable, but he was unable to thrive. He was not improving. He still had fever, high leukocytic count, CRP was high, he can't eat. So after big argumentation, I decided to do another endoscopic drainage. We removed the old stents. As we can see here, 2 on the right, 1 percutaneous drainage, and on the left, 2 CT drainages. And here we have a problem. If you do percutaneous drainage, the cyst is empty. You don't have a fluid component, which will make the endoscopic management very, very difficult in the future. As we can see here, this is the only thing we can see endosonographically. This tiny 2 centimeters or less than 2 centimeters collection. So what I did is just injected through the external drainage a big amount of fluid, hoping that it will reach here, and it did. As you can see here, we see here the turbulence of the water we injected, which allowed us to come inside with a needle, and injecting a huge amount of fluid and contrast metal just to open the necrotic streets or ways. You can see here in the right, there is a huge collection, 70 millimeters and 90 millimeters. And here on the left side, you have 1, and in the peripancreatic, you still have a huge one. And you have a colonic fistula, which happens, I wouldn't say it's rare. You see often with such patients. If you don't drain well, with the inflammation, it can perforate in the colon. So after the puncture, I put a wire and then balloon dilatation. The wire reached here till the external drainage, coming inside the retroperitoneum with the endoscope. And you can see here some pictures of the procedure. On the upper left, the balloon dilatations going inside the cavity. It was a really narrow way to reach the left pelvic area. And here is a video. This is the external drainage. I will go back. This is the external drainage of the left side. So we came inside till we reached it, and we start to do the necrosectomy. You can see how huge and how big is the retroperitoneal areas. And there is another street here, necrotic street on the right side. But we couldn't reach the right pelvic area. So we did our necrosectomy here at the stomach. We did a lot of necrosectomy in this session. But after this drainage, patient's clinical condition improved marvelously. Colonic fistula closed spontaneously. So we did colonoscopy, we did CT with contrast metal to see if the colonic fistula is still open. It closed spontaneously. 9 weeks from the admission, we were digging through the last tunnel, which means the right side. As you can see here, I'm with the scope trying to reach the right side. Finally, succeeded with to put a wire and a cannula and give contrast metal just to make sure that this is the right way. Balloon dilatation of this track here, or this necrotic street. As you can see, there is a waist here of the balloon. Balloon dilated, and then coming inside this area with the scope. This is the right-sided cutaneous drainage. I believe the fistula was somewhere here. I believe the colon is somewhere around here. It is very difficult to estimate the organs from the retroperitoneum. And this is, I think, yes, the last necrosectomy session. Now, after finishing the necrosectomy of the right side, we are removing now the right percutaneous drainage because we don't need it anymore. I think the fistula was might be because of this drainage. Maybe they did iatrogenic perforation. And the presence of the drainage will delay the healing of the tract anyway. That's why we removed all the external drainages. So you come inside again, still a lot of necrosis. And I would like now to show you the how it looked like at the end after finishing the necrosectomy. We achieved complete necrosectomy. So you can see this is the left tract. It's already collapsing in few days. It's a little bit bloody and friable, which is nice. This is another tract in the retroperitoneum. And the final tract on the right side, you will reach it now. Here. And just very distal here, you will see the area where the external drainage and the perforation or the colonic fistula was. So as you can see here, this I would call a full necrosectomy. And as I said, this is a very nice granulation tissue. This bloody granulation tissue will heal very quickly. So at the end, I put 3 pigtails to the left and to the right. So we have 6. You can estimate how long they are because this is at 8 centimeter plastic stent in the bile duct. So I think this were 17 or 18 centimeters double pigtail stents. So we have 6. 10 weeks from admission, patient was totally fine and ready to be discharged. And here is his CT image. Sorry. As you can see, there's a little bit of fluid collection here, which is not a problem. We know that there is no necrosis here, so we are sure that it will heal. And on the right side, it is completely collapsed here. And the patient was doing fine, and he went home. I saw the patient 2 months later during the follow-up. There was no signs of any residuals. This is his CT scan. So I will go through it. This, I will try to find our pigtails. So the left side is completely collapsed here. And the right side is also completely collapsed here. There is no any rest. The patient is totally fine. He can eat well, he can do his sports, he can work again. Everything is fine. So in conclusion, EUS guided drainage and debridement is superior to surgery and to percutaneous drainage. I hope it was a good example to show why percutaneous drainage can be problematic. Of course, you still can do it as primary or complementary options in special cases. That's why you have to discuss it and to plan very well. And the most important statement today is thorough assessment of peripancreatic fluid collections using all possible modalities, CT, endosonography, ultrasound, planning with your radiologist, with your surgeon, with everyone to discuss and discuss and discuss. Then you will have a good strategy, what you will do. Because if I will look at this case retrospectively, by the first drainage, I will try to do balloon dilatation to come inside. At that point, the tracts will not be closed, they will be open, and you can easily put stents here and there, and then after a couple of days, you can start the necrosectomy. Peripancreatic fluid collection should be managed, of course, in highly specialized centers with multidisciplinary teams. You have to have a good radiologist, good surgeons who will be your backup the whole time. Continuous clinical assessment of the patient is very important. They can deteriorate very quickly, these patients. And finally, delay, drain, and debride. Thank you very much.
Thank you, Professor Mohammed, for this excellent lecture and amazing work.
Thank you, Doctor.
Actually, now the floor is open for discussion and for questions. And for me, I have many questions. Excuse me, Dr. Hussein, if yes. First, I would like to ask about the accessories, because we have in Egypt here lack of accessories. We are not, we don't have enough accessories. For example, the hot axios or spaxios stands. So what is your recommendation here in Egypt if we have a case with walled-off necrosis? What is your recommendation if we have only double pigtail and so on? This is one question. Secondly, if we don't have carbon dioxide in each center, actually in our institute in Chidor Belhars, we don't have carbon dioxide, but we do a lot of work by my dear brother, Dr. Khalid Ragab. He is doing very nice interventional EUS drainage and for cysts and even biliary drainage without carbon dioxide. So is carbon dioxide mandatory or not? Because we don't have it in all our centers. Thirdly, as regards the natural course of walled-off necrosis, is it recurring if there is the disconnected duct syndrome? Would it recur once more, and what will be the management? So this may be some questions I have, maybe others, but it's too more. I don't have to waste time. Thank you so much.
Thank you, Dr. Mahmoud, very much for this nice questions. They are very important. So I will go through them quickly. Regarding hot axios, I think Boston will be upset of me, but don't use them with peripancreatic fluid collections. I would say the only real two indications for hot axios would be gastroenterostomy and gallbladder drainage. Okay, so usually if I will use hot axios stent in my department here, is to allow my colleagues to practice how to deploy them before they will go further in any other indications. But regarding peripancreatic fluid collections, I'm a little bit old school. I would like to go with a cystotome, put the wire, do balloon dilatation. As I said, it's quite expensive, and it limits my movement inside the walled-off pancreatic necrosis. I don't see a huge indication for it. Although I have it, I don't use it as a standard for pseudocyst drainage or for walled-off pancreatic necrosis because of these reasons. I think with pigtails, it's more than enough. It's more than enough that you have a needle, that you have a wire, and you have a cystotome and double pigtails. Regarding the carbon dioxide, I would say it is a must. The first reported cases with air embolism during the during the necrosectomy was reported from our department here, which I'm working now. Before I come here, I read about it in Egypt at that time. It was the first fatal case during necrosectomy, and it doesn't take a lot of time. The patient will die immediately. So it's enough to see it once. If you have to do it without CO2, if it is a must, there is no alternative, I would highly recommend to put at least one pigtail or two pigtails inside the cavity before you come inside, which will work as a valve. If the air is highly inflated and the pressure is high inside the cavity, these two stents will release this high pressure, so you will minimize the risk of air embolism. So the air embolism usually will happen only if the pressure is very high and the air will be pressured against the injured blood vessels. The recurrence, it is a very, very important question. The recurrence rate after walled-off pancreatic necrosectomy is more than 33%, which I personally believe it's much more than this. Because if you have a huge necrosis like this guy, which I showed the picture, it is, of course, there's a pancreatic duct disruption. Will he develop pancreatic disconnected duct syndrome? We don't know, but most probably yes. And it doesn't matter. And you can't exclude it with all imaging modalities, with MRCP, even if it is nice, if it is great, you can't exclude it. And I believe the best strategy, don't think about it, put your stents, 3-4 stents, and leave them 1 or 2 years. In best case scenario, when the lumen will collapse of the cavity, that will happen in few days to few weeks. You will develop, if the stents stayed like 1 to 2 years, you will develop a permanent pancreatico-gastric fistula, which is exactly what you want. The pancreas will be fistulizing with the stomach, then all the pancreatic fluid or the pancreatic pressure will be released in the stomach. I believe this. I'm doing this since a long time, and it's working very fine. I didn't have any problem with long time stents. In some patients, I left the stents 3 years, nothing happened. And after removing the stents, also nothing happened. If you remove the stents earlier, like many people are doing, like 3 months or 6 months, and there is no rationale behind it, usually you'll start to see this recurrence of the fluid collection.
Okay, I heard.
Thanks, dear Professor Muhammad. This is Hassan Atala from Mansour University. I want first to thank you about this elegant lecture and the elegant, very nice, amazing case. I want to share you my experience for a similar case. I have seen here in Japan during the last year. He was a gentleman with post-pancreatitis fluid collection. It was large amount of fluid in the peritoneum, even reached the submucosa of the esophagus, bulging mucosa-like versus. And then the management of the Japanese team was to do endoscopic ERCP and endoscopic retropancreatic pancreatography and putting nasopancreatic drainage, nasopancreatic tube to drain the fluid from the main source, from the pancreas. And I think your nice word about the mapping of the fluid in the peritoneum is the first idea in this case. After doing the nasopancreatic drainage, the patient, after I think about 2 weeks, all the flow collection in the peritoneum and even in the esophagus and in the peritoneal recesses was relieved, and the patient has in the follow-up endoscopy, there was no flow collection. So what's your opinion about this idea?
Again, did you mean peritoneal or retroperitoneal collection?
Post-pancreas, very pancreatic fluid collection, and
but it was retroperitoneal usually, or it was peritoneal. Because if it is peritoneal, we are talking from about pancreatic ascites, which is actually a bad condition. It was in the retroperitoneal, I think.
Yes, I think so.
Okay, and it went from the retroperitoneum through the phlegmatic hiatus in the mediastinum. That can happen.
Yes, I think. Yes.
May I ask why they didn't do transluminal drainage?
It was the idea of the Japanese team first. I think they have thought about the disconnected duct syndrome or something like that, and they preferred to do endoscopic treatment first before. And I think maybe due to the large amount of fluid, they preferred to maintain the drainage through the endoscopic through the pancreatic duct itself. I think so.
I think the Japanese school already, they are very, they love the nasobiliary tubes inside the pancreatic duct. They put it always, even after ESD in the duodenum. They are not shy to do it. The literature regarding transpapillary pancreatic drainage versus transluminal, the literature or the evidence didn't show any advance to do transpapillary if the lesions are big. So you can do it if you have a small collection, according to some small retrospective analysis. But actually you can't, if there is a big retroperitoneal fluid collection, especially if there is necrosis, a pancreatic stent through the papilla will not add a lot of advances. You can imagine that the pancreatic duct is completely disrupted and you have put just 7 French or 10 French even pancreatic stent to allow the pancreatic juice will come in the duodenum, but still it's not enough. It will never be enough. So at that case, maybe it helped him, because if you think about it like this, the pancreas would make something like 2 liters secretions per day, which is a huge amount. I think the idea here was to release it in the throughout the nasobiliary to allow the patients to heal. But I would do it differently. I would say, but if it succeeded, maybe it's fine.
They have published it, I think, in Digestive Gastroenterology journal. I think it was published.
Without any transluminal drainage?
Yes. Just
without percutaneous, nothing?
Nasopancreatic drainage only.
Through the papilla?
Yes, through the papilla.
It's good, it's nice to...
And in this case, Dr. Hassan, the distal end of the stent in the pancreatic duct itself, or you put it in the through the disrupted duct into the collection.
I will revise the case again, but I think they have made about 5 French nasopancreatic tube. They have done ARCB and pancreatic wire, and then the endoscope. The wire there, I think 25 gauge wire, and then they put the nasopancreatic tube. I think through the effect. I think till the end of the pancreatic duct. So drainage was secured. I think about 2 weeks. The case was amazing to me. I thought it has a variceal varices due to both pancreatitis, thrombosis, or like that. But it was only just flow collection and bulging mucosa in the esophagus. And then in the follow-up endoscopy, it was relieved totally.
Then the tip of the nasopancreatic tube is in the collection. Is in the collection, not in the pancreatic duct. Yes, he thinks it. Okay, thank you.
I think Dr. Hussein, if there is necrosis, it will never be enough to draw it with the nasobiliary. If it is only fluid, maybe. And if they put the stent from the papilla through the disrupted duct in the collection, then we still have the problem of the disconnected duct syndrome. Then you have to go further to treat it. That's why I will try to find it in the literature to search about it. But
I think I will find the case and send it to you.
Please, that would be great. That would be nice. Thank you.
Yes, first I'd like to thank you very much for the very interesting lecture. I enjoyed it very much, and I enjoyed this case. It's very, very unusual and very nice and very, it's something is like amazing. Yeah,
thank you, Dr. Hassan. Sharaf leh.
I have a simple technical question.
Please.
Last question, simple technical question. When you'd like to put more than double pictical stents, 2 or 3, what is your preferred method? Is to use 10 French cystotome or Sohendra dilator and put 2 wires and then introduce the 7 French first, because 10 French will not go beside the second wire, and then put 10 French stent, or to put a stent very rapidly and then to cannulate again? What is your preferred policy if you want to introduce more than 1 double pigtail stent?
Usually you would like either to put 2, because 1, as I said, it's never enough. So usually you would like to put 2 stents with the first drainage. You don't need more than 2 with the first drainage.
Yes.
2 are usually enough. So if you will use 10 French cystotome, you can put the second wire after you come inside with the cystotome. You can put the second wire and then you put 2 stents. You don't need to dilate. 10 French cystotome will be enough to 2 7 French pigtails.
Yes, if you don't.
If you would like to do more stents, that means we are talking about necrosis now. So usually you will do balloon dilatation to come inside the cavity. If you do dilatation, it wouldn't be a problem. Then you can put 3, 4, 5 stents as much as you need.
By cannulation, by cystotome like that, or something like that, or a cannula?
After the balloon dilatation or without?
After or even with?
No, if you will drain for the first time, you will need the cystotome, and then when you use 10 French cystotome, you can put 2 wires through it, and then you can put over the 2 wires 2 pigtails.
Yes, but if you have 10 French cystotome.
Yes, this is with 10 French cystotome. You put 2 wires and 2 7 French pigtails.
If you don't have 10
If I don't have it, okay, now I can hear you. If you don't have it, if you have 8 French or something, then you have to do balloon dilatation. Then it is a must to do balloon dilatation.
And then cannulate beside.
And then you cannulate, yes. and then you cannulate after you do the dilatation. I wouldn't recommend to put 1/7 French stent, because sometimes, and I saw it twice or three times, that after putting the stent and you are trying to cannulate beside the pigtail, your wire can go somewhere else, which wouldn't be nice. So, and I don't know, it can perforate or can go in submucosa or something. So I would recommend to do balloon dilatation first. So you will have more freedom to put the second wire.
Yeah, at least up to 12 millimeter, for example.
You can go aggressive with retroperitoneal. They are usually stable. You can go with 15, 16, 18, whatever you like. If you are suspecting necrosis, you can take this chance to do 18 millimeter, and then you go at the same session with the scope inside the cavity.
And what scope you are using? 7 millimeter diameter, like
no, just normal Olympus 190 endoscope.
Yeah.
We had 9 to 10 millimeters, I think.
No need for pediatric.
No, actually, when I have I have two endoscopes which has diameters of 12 millimeters, therapeutic upper endoscopies, which I usually love to use them with necrosectomy. You have more suction power. They have big working channel. When I have these devices, when they are not in use, then I use them. So go with bigger devices with big working channel. It is much better. With necrosis, unfortunately, you have to be aggressive.
Yeah. Then very nice lecture and very nice discussion and very unusual.
Thank you, Dr. Hussein. Thank you very much for your invitation.
Thank you, Muhammad. Thank you so much.
Thank you, Dr. Mahmoud. Thank you very much.
Then we get to the third patient message in the videos. We start with Dr. Saad Ghulam. Ahmed. Who's ready? Dr. Jalal, Dr. Said.
Ahmed Jalal is with us.
I'm ready.
Yes.
Okay, Dr. Jalal, can you share your screen?
Okay. Can you see it?
Yes, we can, Dr. Jalal.
In the first, I would thank Dr. Hussein for this invitation. I'm happy to be with my professor here. Today we will present a case. It is the message in a case. Our case, 59 years old male patient complaining of severe dyspepsia, weight loss, and severe vomiting. In March 2021, upper endoscopy shows severe thick and edematous wall, suspicion of neoplastic process, pathology, superficial gastritis. CT in this year showed a few thickened gastric wall, linitis plastica. Upper endoscopy repeated 2 times with the same result. Severe dysphagia was also developed, and the last endoscopy passed the GE junction with great difficulty. He sent for EUS, but his decision to do EUS was very late. Patient sent for EUS in August for EUS FMB and from the second gastric wall. The EUS scope couldn't pass the GE junction. It was very tight opening. So I go with the regular scope, but I pass also with very difficulty with high suspicion of malignant gastric lesion. This is a video of the upper endoscopy. That was the tight GE junction with the very small opening. I try to pass with just gentle pressure. I succeed to pass, and I suck the fluid. This is the mucosa. And very short stomach, then I go for duodenum. The second part, duodenum. The pulp, the first part, and the stomach is very limited distension with very thick wall. That's the MBI of the gastric wall. My opinion here is to do the EUS till the GE junction and let the needle pass and so. We see here the aorta, the left atrium, pulmonary, to see any lymph node in this area, no lymph node. We go to the GE junction, we could see the aorta, the celiac and superior mesenteric artery. That is the sick wall, that is the liver, that is the heart and left ventricle. We here can see the sick wall of the esophagus and the stomach. The curved area of the EUS could see below it, so we can see this area. We measure it 7.5 millimeter and in some parts reach 17. That's the liver and that's the sick wall. That's the GE junction. That's the elastography. It was more hard at that part. So we go with the needle and let the needle go and do the job below the structure. That is the wall. And that's the needle inside the stomach. We try to make fanning. From that part and from that part by changing the position. We took from this hard part. The pathology show positive malignant cell, signet ring carcinoma. My take-home message: if you suspect malignancy and the regular biopsy is negative, EUS is mandatory for take the deep biopsy from all layer. If you find a structure, reach it with the scope and let the needle go to do the job and to the target. The probe can see below the structure. Thank you very much.
We will have 5 minutes for discussion. Any questions from the floor?
I have a question, Dr. Hussein.
Yes, Fadl.
Dr. Ahmed, very nice case. Thank you very much. Just a question, why didn't balloon dilatation before this?
It was an option, but I didn't do it. I afraid from the malignancy. Yeah.
Okay.
Excuse me, Professor Hamad Hafiz, we did a large scale job and in Cairo University, and it was published in Endoscopic Ultrasound Journal and Turkish Journal of Gastroenterology in 107 cases of such like over the last 5 or 6 years, and all cases, most of the cases have strictures, whether in the pyloric ring, or at the cardia, and we did the job by sending the needle at the stricture site to do the job far away from the stricture site, and our accuracy was 73 or 74%.
Great.
So I am with Dr. Ahmed Galal that in many cases no need to do dilatation with some complications, as you know. Just stand at the stricture site and send the needle to do the job. And you know that it's very nicely the EUS can see up to 3 or 4 or 5 centimeters below the location of the endoscope, because the plane of view is a sector and not a rectangle. So sometimes you can know the extension of the lesion inside the stomach while you are standing at the esophagus as the stricture site. So congratulate Dr. Ahmed Galal for the very nice job. My question to you, we noticed in our series that fine needle biopsy is much more yielding in this situation than fine needle aspiration. Did you do FNB or FNA? Because in many instances, these lesions proved to be lymphoma, which needs, of course, sufficient tissue for immunohistochemistry with CD markers, a large number of CD markers, and in some of our cases proved to be eosinophilic gastroenteritis, especially in lesions with pyloric stenosis. So did you use FNA or FNB?
FNB.
NB. And you confirmed by immunohistochemistry like cytokeratin, adenocarcinoma, and cytokeratin. Yes.
Yeah, and the patient sent for chemotherapy as he is not candidate for surgery, and I prefer to do stenting in that area because the patient can eat and drink, but unfortunately the patient died after 1 month.
Okay, so another second take-home message that it is better to use FNB rather than FNA for possible immune staining.
Yeah.
You agree with me?
I agree with you. Yeah, I use FNB now with all my cases, except when there is only FNA in my institute, or if the lesion in the Anselm process, I prefer to do it with 25 gene FNA needle.
25?
In Anselm process, yeah.
FNB, 25 in FNB.
FNA, we don't have FNB 25. We use FNA in Anselm process if we the scope is getting curved. I prefer to do the EUS FNA with the 25 G needed.
In the deep second part of the tube.
Yeah, in the deep second one, in the answer process. If I can get it from the bulb, I use FNB needed.
Yes. But for me, it is 22 FNA is usually managing, almost always managing.
Yeah.
If it is FNA. So
yeah.
22 is sufficient. 25, I think, is material will be, but if it works with you, then it is okay.
I think there is a study last year that an FNA, 25 FNA get more tissue than 22.
25?
Do you read the study?
More than 22.
Yeah.
Yeah, okay. But to me, my
okay.
is telling the opposite. Probably when I use 25 to the first time, I get insufficient sample. So it is maybe bad luck for me. So I never use 25 after that. But we should believe the work of others. And thank you very much for the very nice case and very straightforward take-home messages in your case. Any other questions? Thank you. Dr. Rasha will introduce Dr. Syed Ghanim.
Now we are introducing Dr. Syed Ghanim. He is going to give us a message in a video from Mansoura University.
Assalamu alaikum. I will present rapidly a case of EUS-guided choledochoduodenostomy. "64-year-old male presented to ER 4 months ago with gastric outlet obstructive symptoms. He did gastrogenostomy for advanced duodenal tumor with regression of gastric outlet symptoms. Presented us 2 weeks ago by obstructive jaundice. We plan to do EUS-guided belly drainage. This is the EGD for the patient to delineate the anatomy, the pylorus. We enter to the D1 and the tumor obstructing D1. We did EGD to plan to do either we can do choledochoduodenostomy or HGS. This is a video for CDS. First, we nestle the scoop in the D1 and inject after puncture the CBD with 19 gauge needle, contrast injection, and the guide wire toward the intrahepatic B radicals. Always we maintain the wire in the EUS view. Then making the track with 6 French stone. Always we try to maintain the guide wire in the EUS view. And then when we introduce the stent, unfortunately we have only half to half 6 centimeter stent. We deploy it under endoscopic and fluoroscopic and EUS view. Now we completely deploy the stent with good drainage. But under the fluoroscopy, I noticed that the middle of the stent is inside the wall. The middle of the stent means the upper part is uncovered. So there is high risk of leakage. So I decided to put a second stent inside this stent. Now we introduce the stent. And then complete deployment. So sufficient length in the duodenum with good drainage. And under fluoroscopy, there is no leakage and good positioning of the stent inside the CBD. My message here is to keep the stable position and direct the scope, the echo endoscope towards the hilum, and maintain the guide wire in EUS view all over the maneuver. Use 6 French stone. Many studies suggest that tubular stent more preferred than LAMS. Partially covered or fully covered stent should be used, not to use short stent with half to half character, as there is high risk of leakage due to uncovered part may be deployed through the lumen. Don't remove the guide wire except after completely finish the procedure. Thank you.
Thank you. Thank you, Professor Said, for this excellent job. I have some questions, some clarifications. I need some clarifications. How to maintain the position of the guide wire to be stable in EUS? Do you insert the guide wire till you reach upwards to the biliary system inside the branches of the intrahepatic radicals, or you keep the guide wire for a short distance so you are concentrating on the EUS image, not on the fluoroscopic image? This is one question. The second, what is the type of stent you use in the second time? The second stent you do.
Yes, I mean.
But it's very nice work. Indeed,
I mean, keep
excellent work.
Keep EUS view of the wire. The echo endoscope is the wire. Keep the scope and اقصد يعني تحط الواير alignment ان الواير يبقى في نفس اتجاه الايكو اندوسكوب بحيث ان to make a change of the accessories very easy.
Do you need the assistant to fix the echo endoscope?
No. Try to keep the scope in the same position.
Yes.
Not to change it. It means that the wire in the alignment in the same line with the echo endoscope. So accessories, exchange of the accessories would be easy.
To what extent you introduce the guide wire inside the biliary system?
Into hepatic B radicals, either right or left. This is under the screen.
Yes.
But I mean not to change the scope position and lose the wire. It will make change the accessories very difficult.
And
the second stent is the 8 centimeter partially covered stent.
Yes. Thank you.
Then why don't use the second stent as the first one?
As I fear to short stent is preferred in CDS long stent not preferred I fear to occlude the cystic duct at the start, but
there's another question. If this patient, the life expectancy is important in such cases, because if the patient improved by any neoadjuvant treatment or something, can you remove the stent?
The patient is on chemotherapy. He stopped chemotherapy due to increased serum bilirubin, and his very general condition is very well. He need only to drain the CBD to continue chemotherapy.
Yes, but if he improved, for example, if there is a patient improving on chemotherapy or something, can you remove the stent? What type of stent you can remove, and what type of stents you can't remove?
We can remove the fully covered stent, but in this patient we don't need to remove it.
If it is partially covered,
I think it's hazardous to remove it.
Yes, you can remove it. Yes.
يعني هو في الاي ار سي زي ما حضرتك عارف ايه، في البارشل كفرد اي ار سي بي غالبا ديفيكولت في الريموفال، تمام، وخاصه لو عدى مثلا اكتر من يومين بعد فول ديبلويمنت اوف ذا ستنت او راديال فورس بتاع الستنت. اللي لاحظناه في الكولودوكولونوستومي الانجوليشن بتاع الستنت نفسها بتخلي الريموفال سهل. وايفن احنا عندنا في الاستادي اللي ان شاء الله ربنا يكرم نعرف ننشرها بس 91 حاله، احنا عندنا المايجريشن حصل في الفولي كفر وفي البارشلي كفر ستنت سبونتينيوسلي بعد الفيستولا تراك. لو حضرتك تيجي تبص بقى بعد ما بتعمل فول اب للعيان، لو عيان مثلا حضرتك متابعه وبتبص عليه بعد كده بتلاقي قصه الميتاليك ستنت على السكرين تبقى واخده السي بي دي، وبعد كده انت عامل اكيوت انجوليشن وطالعه على البلب. فالاكيوت انجوليشن بتاعها ده مع الفولي ديبلويمنت اوف ذا ستنت والراديال فورس بتاعها بيحصل شورتنج جامد جدا. يعني السته ديت فعلا لو سيد ما كانش حاطط دعامه كانت هتلاقيها مايجريت، ممكن ايفن حتى تنزل بريتونيل. كنا لسه بنتكلم انا ومعاذ تحط جواها بلاستيك ستنت عادي، والام بتاعك بتاع البلاستيك مش ان انت خايف من الليك، ان انت خايف من الانترنال من الاكسترنال من الانترنال بريتونيال مايجريشن بتاع الستنت. الليك كده كده بالبلاستيك ستنت هيقف، فانت بتحاول تمنتين الايه الانجل بتاع الستنت بالنسبه لك. ما حاولناش بصراحه ان احنا نشيل الستنت بنفسنا، بس اكتر من ستنت بتشوفهم في الفول اب بتاع العيان بتلاقي الستنت اوريدي اللي انت سايبها 2 3 سم، احنا بنسيب 3 سم بتلاقيهم مثلا وصلوا ل 5 سم، ويا دوبك ستامب صغير من الستنت موجود في جوه السي بي دي. فهي انا تفسيري اعتقادي ان عكس طبعا السي بي دي العاديه، السي بي دي كل 8 سم راشقين في السي بي دي بستريت، فبالتالي التيشو امبيدنج بتاع البيلاري سيستم عليها على البارشل على الجزء اللي هو الانكفر بيمنع شويه الايه الريموفال بتاع البارشل.
انا عاوز اوصل لكونكلوجن. what preferable stent in colodocodostomy؟
انت بنتكلم على فولي كفرد بارشلي كفر. احنا بالنسبه لنا
الكفرد هتبقى فيه مايجريشن، يبقى لازم اعمل فيكسيشن.
عشان كده احنا بالنسبه لنا احنا بالنسبه لنا يعني احنا سيتلد بناخد العين بارشلي كفرد، يعني ماي اور ريكومنديشن احنا بناخد كل البارشلي كفرد.
بس هو برضه يا خالد المايجريشن او الشورتنج كان واضح اكتر مع العيانين بتوع الاتش جي اس مش السي دي اس. يعني السي دي اس لو سن 3 سم موجودين بيبقوا سفشنت خالص وما بيحصلش شورتنج جامد، على عكس
الاتش جي اس. طبعا يعني احنا هنحاول نشوفها في الحلقه الجايه ان شاء الله. الاتش جي اس المسافه الطويله والسبيس الكبير والانسبيريشن بتاع الديافرام، كل الحاجات دي كلها بتخلي مفيش فيستولا تراك ومفيش نوت يعني مينترنس للستنت، عشان كده الانسيدنس اعلى. عشان كده كل ما تبقى الستنت اطول كل ما يبقى افضل بالنسبه لنا. يعني 10 سنتيمتر نوت اللي هي الموجوده حاليا في مصر الاتش جي اس افضل من 8. ايفن حتى طبعا 6 استحاله التاريخ او يعني مش ريكومندد تماما، حتى بالجايد لاينز بتاعت الاوروبيان سوسايتي اوف جاسترونترولوجي اند اندوسكوبي ان هو لما كانوا بيعملوه كاكسبرت اوبينيونز كلهم اعترضوا على 6، وجزء وافق على 8 والاكثر وافق على الايه على 10 في الاتش جي اس. اليابانيين كلهم بيستخدموا الاتش جي اس خلاص، بس فكره بيستخدم دعامه طويله 10 سم وفي 12 سم خلاص. هنا احنا حتى عشان نستعيد عن القصه دي نحاول ان احنا عندنا 10 سم في مصر موجوده 12 سم فولي كفرد، فممكن تركبها، بس انت بقى حاطط في اعتبارك الفرق ما بين ان يحصل سايد برانش اوبستراكشن في انيشال اوبستراكشن، بس عندك ميزه ان انت تعرف تشيل الايه تعرف تشيل الستنت، فدي اوبشن بالنسبه لك تعرف تكانيوليت من خلالها. ودي نقطه مهمه عشان لو العيان بوردر لاين ما تحرموش انت من فرصه الايه الجراحه. انما لو العيان بالنسبه لنا ريسكتابل حط الاتش جي اس ستنت او البارشل ريكفرد ستنت، باعتبار ان انت مش هتعرف تشيلها او حتى على الاقل هيبقى في صعوبه في الايه في الشيل بتاعها. تمام. فاحنا هنحط فولي كفرد يا نحط بلاستيك ستنت من باب لو العيان بوردر لاين ريسكتابل او ريسكتابل. في الكولودوكودونوستومي لو العيان ريسكتابل او حتى بارشل او هو يعني بوردر لاين، هو اوريدي احنا غالبا بنحاول قدر الامكان ما نحطش عند الهايلم عشان ما يقفلش ايه. فانت اوريدي سايب له ستامب صغير 1 أو 2 سنتيمتر، ايفن حتى لو هو ما قدرش يشيل الستنت فبيشيلها اثناء السيرجيكال. ما بتبقاش سهله او بتبقى صعبه للجراح شويه، بس على الاقل انت سايب له 2 سم بالنسبه لك. فانت ما بين السيفتي عشان التكنيك بالنسبه لك وما بين بعد كده الفيوتشر ثيرابي. عشان كده سيد حاول يحط حاجه صغيره في الاول، اعتقادي انه كان بيحاول يفكر ان تبقى حاجه صغيره عشان الجراح بعد كده لو هيشيل
هو بصراحه السؤال عن كده ادفانس من الاول، بس انا حطيت انا حضرتك اتكلمت عن نوع الستنت، احنا بنتكلم على اللينس من جهه ونوع الستنت نفسها من جهه. اللينس بتاع الستنت انا يعني نفسي انا بفضل ال 6 سم في ال 6 سنتيمتر في الكولودوكودونوستوم. الحاجه الثانيه نوع الستنت، يعني عن تجربه في كل الحالات اللي احنا اشتغلناها، الحالات الاستنتات اللي بتبقى فيها هاي راديال فورس هي دي بيحصل في كل المشاكل اللي حصلت معانا، حصلت من الاستنت اللي فيها راديال فورس عالي. يعني بتاعت بوسطن بالذات، بتاعت بوسطن الراديال فورس بتاعها عالي، فما بتفتح ميزتها انها بتفتح بسرعه وبتفتح كويس قدام، بس مشكلتها مع الايام بتقصر. يعني حتى كانوا كاتبين حتى انها ممكن توصل ل 40% شورتنج، يعني لو قدامك على السكرين طولها واضح بعد شويه بتلاقيها اقصر من الطول اللي انت حاطه ده. ما بخافش منها في الكولودوكودونوستوم قوي، بس فعلا بتبقى مشكله في الهيباتوكوجاستروستوم. يعني معايا حاله انترنال مايجريشن بيرتونال مايجريشن، مع اني كنت سايبها اكتر من 3 سم جوه الاستومك، بعدها بيومين 2 حسن حتى الحاله كانت معانا بعدها بيومين الحاله كانت انترنال مايجريشن في البيرتونال، مع اننا سايبينها حوالي اكتر من 3 سم جوه.
يعني انترنال
ليه؟ في الكولودوكودونوستوم 6 سنتيمتر ريستنت partially or fully covered. partially covered or fully covered. هو البلاستيك ستنت مشكله البيك تيل ان احنا عشان نحطها بسهوله لازم توسع، فبتكونسيوم تايم واحنا ما بنشتغلش بسي او 2 وكلام من ده. فبصراحه انا عمري ما حطيت فيها ستنت، يعني كل حاجه ما حطيتش فيها ستنت بصراحه.
Okay, thank you, Dr. Said. There are many take-home messages from your very interesting case. And last question because
كنت عايز اسال سؤال، بس هو في المسجز كان
can we speak in English?
in messages there was self-expanding metallic stent is preferred to lamps. We are in new era of lamps. Why not use the lamps 8 millimeters and 6 millimeters? Hot axis, new hot axis.
There is many problem with lamps in CDS. First, there is high incidence of food impaction. Second, there is high incidence also in thumb syndrome. There is a collection of bile and debris below the stent. This increase the risk of cholangitis. And the main problem, if there is not markedly dilated, you may puncture the other side of the CBD. And so tubular stent is more preferred than lamps.
Now it's my pleasure to introduce my dear friend and dear brother, Dr. Khalid Rajab, Tidor Institute, who will give us a message in a video.
شكرا جزيلا، وسعداء بالدعوه كمان استاذنا الدكتور حسين عكاشه يعني واستاذ الدكتور محمود الانصاري وجميع الزملاء الافاضل واصحابي في القاعه. المسج بتاعتنا النهارده ان فيديو هتبقى يعني تكمله ل
please can you speak in all English because there are many people on the Zoom.
Okay.
And they are not from Egypt.
Okay. This is our case now. This young male patient 35 years old with a case of obstructive jaundice. The patient with gastric outlet obstruction and failed of ERCP twice before coming to referred to our institute. As you see here in CT CAT scan, there is multiple hepatic focal lesion, and with by MRCP also there is moderate dilatation of intrahepatic and common bile duct dilatation. In this case, the patient was referred for possibility of EUS guided biliary drainage. As we know, the different types of EUS guided biliary drainage, hepatogastrostomy, choledochodonostomy, and antegrade and rendezvous. In this case, we try to give the patient his last option by endoscopic ultrasound guided drainage. And as you see here, by endoscopic ultrasound, there is large mass in the head of the pancreas with proximal with obstruction of the common bile duct, and also there is encasement of the portal vein. And the endoscopic imaging for this patient was clearly demonstrating that there is gastric outlet obstruction. So our target here to perform hepatogastrostomy for this patient, and during examination of the left loop of the liver, we show this hepatic focal lesion with moderate intrahepatic dilatation. So we recommend for hepatogastrostomy for this patient. We usually we prefer to choose the segment 3. The angulation of the segment 3 prevent the migration of the stent, and so we puncture this segment 3. And after confirmation by bile aspirate, and then we inject.
Khalid, is it easy to demonstrate segment 3? While there is intrahepatic periradical dilatation marked, because it's not clear here, do you have to see the umbilical portion and the ligamentum teres to delineate the segment 3 in this video? I'm sorry for interruption.
Okay, can we answer after?
Please.
Okay.
So postpone all the questions to after finish.
Okay, so after injection of the contrast, as you see here, this moderate intrahepatic dilatation of the biliary system. Then the point here during introducing of the guide wire first passed to the periphery of the intrahepatic. So we don't recommend this direction of the guide wire. So we use what's called a tissue impaction method, and this is our message. If you cannot pass to the hilum of the biliary system, you can use this method, which means you will withdraw your needle for a few millimeters. Then you again pass your guide wire, and the tissue will, as you know, we have a fine needle like a lateral bifield of the needle of the peripheral, the tip of the needle. So the tissue will obliterate this bifield end and will direct your guide wire to the other side of the biliary system, which is the hilum of the liver. So it will help me to have more and more wire during introduction of the guide wire, and this is will give me a chance for, as you see here, this guide wire now go to the hilum. Then we dilate our track. Usually we prefer to dilate in comparison to our Japanese group, we prefer the cystosome to dilate the track. Then we and this cystosome was 6 French cystosome. And lastly, without any further dilatation of the track, we put a metallic guide wire, metallic stent, which is HGS stent, 10 millimeter, 10 centimeter HGS stent. HGS stent is two-thirds of the stent is fully covered, and 1/3 is uncovered, and the proximal end of the stent is double fold. It is 20 millimeter. So the shaft is 10 millimeter, and this flange is 20 millimeter to avoid or prevent further migration of our stent. This is our standard technique in HGS. Now, if you have availability of HGS stent, it would be better. If sometimes and in some interval of the year there is no HGS stent, so we prefer to use half and half stent. But also now we shift to a new era of our ongoing study, to have an HGS plastic stent. Okay, so you should know that we are in limited resources country, like in Egypt. Now we can use a plastic stent, and this is one of our cases during using of HGS plastic stent. as you see here, this is our case. We already performed HGS biplastic double pigtail, and after 4 weeks, the patient obstructed again. So we cannulate through the adjacent to the iatrogenic fistula tract in HGS. So I remove the previous old obliterated plastic stent and cannulate from the stomach like an iatrogenic papilla. Okay, so this is new papilla or this de novo papilla. Now we cannulate from the stomach and we put our guide wire. And after manipulation, and of course during cholangiogram, now we are sure that we are in the intrahepatic biliary system after injection of the contrast. So after this, now we can, like you see here, this is the tract, and this is the intrahepatic tract, and this is the fistula tract. And as you see during introduction, even the guide wire, the fistula tract more of a large amount of moderate amount of bile came out from the fistula tract, which is a good sign of mature fistula tract. So this is the last step. We bought a 10 centimeter 10 French plastic stent and or 12 centimeter plastic stent, and the aim here to maintain the fistula tract. And now we shift from this metallic stent to plastic stent, and we save more time, more cost or more money for this patient. And one more advantage for this, we can more and more change or replacement of this plastic stent and give us the advantage or the benefit of fully covered stent that you can remove, and you are not against to or apporting the possibility for the surgery for your patient. So our message is EUS guide biliary drainage now is accepted, could be done by both metallic stent and the plastic stent, especially in cases of HGS with accepted both technical and clinical outcome. Thank you very much. معايا فيديو تاني لو حضراتكم. احنا خلصنا الوقت ولا في؟
As you like.
اوكي، معايا فيديو تاني سريع. ممكن. شكرا يا رب. يعني هو بعيد خالص، هو جزء دايجنوستيك لو حضرتك تحب تشوفوه.
But there are many very nice case. You issued a very important 2 points messages, 2 points really very important, and thank you very much for touching these very difficult subjects and offering your experience in that messages. I have a question for you. In the second time, by cannulating the papilla after removing the double pigtail stent, you entered by the upper endoscope, duodenoscope, or EUS also?
Yes, good points. It's by ERCP.
By ERCP, yes, very nice, very manipulative and very nice manipulations, and you can do it as you are doing ERCP from the normal papilla.
You know, Dr. Hussein, in hepatic gastrostomy, you puncture the anterior wall of the stomach.
Yes.
Okay. So our position in the anterior wall of the stomach will not stable by conventional straight scope. So if you wanted to go by right left, it will not give you a chance to cannulate. So you will be tangential to the papilla. You cannot cannulate. Even by EUS, it is difficult as the anterior segment of EUS is long segment. Again, in comparison to the ERCP with short segment, and the anterior segment of the ERCP and the EUS. About half of EUS, so it will give you more manipulation by ERCP, and it's better to cannulate by ERCP. This is in comparison to endoscopic necrosectomy. You can go by conventional endoscopy. In endoscopic necrosectomy, you penetrate the posterior wall. The posterior wall is easier to pass through the tract and through the cavity for this patient.
Yes, very interesting. Another question: the plastic stent you use, double pigtail stent. It is very difficult. Sometimes I agree. I congratulate you because when you use double pigtail, it is somewhat difficult to introduce the proximal double pigtail. Even that sometimes difficult even in usual ERCP. In ERCP, I am introducing double pigtail, especially if the papilla is widely opened. So I use double pigtail because the double pigtail, if it is stiff, it has an angle even over the wire and the 5 French sheets. So why not using a single pigtail, not double pigtail, to make things easier to use, especially in the proximal flanks?
Yeah. يعني my technique to your recommendation, but I usually we have in our cases of EUS biliary drainage, we have 2 cases of biliary leakage. So I'm afraid from biliary leakage. Okay, biliary leakage with biliary peritonitis is very difficult points, and the patient يعني الhospital stay بتاعه duplicate يعني at least not 14 days. Okay, and during 14 days you are anxious and irritable for the outcome of your procedure. So we have now either to use the EGS metallic stent or double pigtail to avoid either internal or external migration of my stent. I agree with you that the introduction of the stent will be difficult. That's why we modify our technique to dilate the track to 4 mm 6 mm. يعني عكس ال HGS بحط السيستوم and direct in the metallic stent, but in plastic stent you should dilate. That's why it will take a longer duration. You will dilate by 4 mm.
By a balloon? 4
by
millimeter balloon.
4 millimeter, and we have like
even in HGS.
HGS I dilate by 4 millimeter. 4 millimeter now standard for us 4 to 6 millimeter in HGS plastic stent.
Yes.
HGS plastic stent to avoid or to facilitate the introduction of the stent.
And you dilate at many levels because it is the track
the
is
gastric wall and in the liver, and that's very good points. You should dilate the biliary system also, the wall of the biliary system. You know the tough wall of the biliary system. Sometimes you dilate the tract, the gastric wall, and dilate the liver. And during introduction of your stent, you cannot introduce just the 5 French inner sheaths introduced without introduction of the plastic stent. That's why you missed to dilate the wall of the biliary system. And that is very technical point. We got it after failure, after some technical failure during the introduction of our plastic stent.
Then you dilate at 3 levels.
At least 2 levels. One in the biliary system liver and one liver gastric. That's our policy.
Okay, very interesting. You are always introducing very interesting. Yeah. Dr. Mohammed,
thank you, Khalid. Perfect as usual. Thank you, Khalid. Perfect as usual. In the first video, I would like to ask why you choose HGS instead of CDS. Especially, you can recognize dilated CBD in line of your needle.
Right.
Why you choose GS?
Yes. You can do both of them, okay? But the advantage of HGS in comparison to the advantage of HGS in comparison to CDS, you will have a lower rate of obstructed stent, okay? In HGS, it's higher and away from the pathology, which is the cancer pancreas. But if you perform choledochoduostomy, even if you perform it from the bulb, which is our first, the position may be unstable. You introduce not in long scope, okay? So this is make your scope unstable, and during introduction of during puncture, you can slip to the stomach, and you can make a failure. Anatomy. This point, and another point, the rate of obstruction of the stent is higher in this type of patient in choledochoduostomy in comparison to HGS.
Okay, then thank you very much. Very nice video. Very nice take-home messages. We very valuable and we benefited very much. Thank you. And now it is the time for the second, the third, I think, speaker. Dr. Mariam Zaghloul is with us on the Zoom.
I'm just searching for sharing screen. Yes. Can you see my screen now?
Not yet. Yes, now it is very clear. Yes, thank you.
Yes. Thank you. Shall I start?
Professor Mariam.
Yes, Professor Mahmoud. Nice to be with you tonight.
So it's nice to be with you also, Professor Mariam.
Okay.
Go on, Professor.
Yeah. Thank you for the kind invitation and giving me the chance to present my clinical case. It's a common cause of obstructive jaundice in a patient with hepatocellular carcinoma. Our patient is a 58 years old male patient with a multifocal HCC that have done three sessions of TACE. The last one was for a lymph node that was presented after the second TACE. The patient was kept on with his oncologist on regorafenib 40 milligram TID and presented to our unit with progressive jaundice. The total bilirubin was 44 milligram per deciliter and the direct was almost 30. ALT 49 international unit, AST 98 international unit, albumin 3.6 milligram per deciliter, and alpha fetoprotein is markedly elevated 12,000. On abdominal ultrasound examination, the abdominal ultrasound showed dilated CBD and non-calcular gallbladder distension. The CT exam showed an intense lipidol trapping in both the hepatic focal lesion and the lymph node that was injected. A decision of ERCP was taken to relieve this biliary obstruction. On ERCP, there was a rounded dye-filled structure. Let me change the pointer. Yes, this rounded structure filled with dye in the middle and lower CBD. We thought of a biliary leak, but this was impossible due to localized nature of the lesion and the possibility of a choledochal cyst type 3 was proposed. A plastic stent 12 centimeter by 10 French was inserted with a good biliary drainage. However, the dye retained in the lesion. A decision to introduce the EUS scope was taken. On EUS examination, we have seen this cystic lesion consistent with the injected lymph node with heterogeneous content. We will see in the next video. Examination from the bulb, you can see quite clearly this cystic lesion. This is the portal vein, this is the liver, and this is the confluence with the superior mesenteric going down here. And our stent is here, totally encased by this cystic lesion. To confirm the nature of the fluid inside, and a needle was inserted, and we aspirated, we drained only bile. This is consistent. This is a lymph node liquefied, totally liquefied and taken into the CBD. As regards the cause of obstructive jaundice in this patient, our patient firstly developed jaundice following a nodal injection and regorafenib therapy. The hepatic decompensation could be thought of after regorafenib start, but the full lab showed it's a purely obstructive jaundice. ERCP suggested a suspicion of a choledochal cyst, but that was rapidly excluded when the dye failed to be drained through the limited sphincterotomy and the stent insertion was a little bit difficult. The EUS showed that the cystic lesion with heterogeneous content encasing the plastic stent, which is consistent with the lymph node. The lymph node, after injection, will develop liquefactive necrosis that will erode into the CBD, and the bile leak inside the necrotic lymph node will make it sizable enough to compress the CBD and manifest as obstructive jaundice. The follow-up of this patient showed marvelous improvement. The bilirubin dropped from 44 to 6.4 only after 2 weeks. In this case, we emphasize that the use of EUS in tandem with ERCP helped the final characterization of the cause of the obstructive jaundice in our patient, who could have been missed if we didn't EUS, which is a choledochal nodal cyst. The future concern we are tackling here, we have, if we revise this literature, we find that the role of the EUS is clearly understood in the pancreatic cancer with local ablation, brachytherapy, and direct injection of anti-tumor agent. While in HCC, there is a problem. There is only paucity of evidence and a few case reports reporting interventions only in inaccessible percutaneous cases. And we are wondering, our professors, and what will be the future of EUS in HCC management? And thank you for your attention.
Thank you very much for this very unusual, very unusual case and very interesting case. And any questions from the floor? Regarding your comment about the role of EUS in HCC, I think it may have a role in radiofrequency ablation of single, solitary, or two liver metastases in cases of tumors elsewhere. And I read some articles about use of EUS radiofrequency ablation in small liver metastases in colonic tumors, I think so. What is interesting is that lesions anatomically difficult to CT or EUS guidance is very easy for EUS guidance, and vice versa. So I think it may have a role in radiofrequency ablation of single or double metastasis after, of course, surgical excision of the primary tumor. The question: why not do segmentectomy, hepatic segmentectomy of the liver metastasis in addition to surgical excision of the primary? Sometimes the two metastases are in two different segments of the liver, so it is very difficult to surgically remove more than one segment of the liver. So it is better to do radiofrequency ablation during endoscopic ultrasound guidance. Anyone from the floor can suggest other function of EUS in HCC or liver metastasis? And I think also alcohol injection may work.
Yes. Yes, dear professor, you have explained clearly how to examine the liver by the endoscopic ultrasound, and I searched the literature. I found only few case reports of alcohol ablation through the endoscopic ultrasound, and also some radiofrequency cases. It's not taken into wide range of application or a clinical trial. That's what I am calling why we are not arranging some research like that.
And I met one of my colleagues, doctors who went in Germany to inject lymph node, to do radiofrequency ablation of a solitary metastatic lymph node. So I think there are many trials in that context, but at the end, it is sporadic cases and no consensus, no definite protocols of the use of EUS guidance of ablation of liver metastasis or metastatic lymph nodes. Maybe in the future.
Yes.
Okay, any other comments? Thank you very much for Dr. Mariam Salah for this very interesting and very unusual. I think this case will see it once in a life. So thank you to showing very rare and very interesting case. Now,
thank you, dear professor, for an invitation. Thank you.
Now we shift to the second speaker, my dear brother and colleague, Dr. Ahmed Zamzami. I don't know the case, video case, but I'm sure that it will be informative and interesting. Thank you,
our dear professor. At the beginning, I would like to present my profound thanks and deep appreciation to our great mentor, Professor Hussein Okesha, for his endless support. My talk today about EUS guided radiofrequency ablation of pancreatic neoplasm. A 40-year-old male patient presented with recurrent attack of hypoglycemia for 3 years. Abdominal CT show no evidence of pancreatic masses, while EUS revealed a well-defined hypoechoic focal lesion about 2 cm in diameter, located at the pancreatic neck, close to the confluence of portal vein. Picture was highly impressive of neuroendocrinal tumor, mostly in selenoma, while cytopathological assessment revealed a neuroendocrine tumor for immunophenotyping confirmation. In the stomach station, as we see, is a confluence and a hypoechoic focal lesion, very clear, close to it. It was about 2 cm in diameter and present at the neck of the pancreas. We measure it. It was, as I mentioned, about 2 cm by 1.8 cm in diameter. And finally, by applying Doppler, it was highly vascular, highly impressive of insulinoma. What to do next? As we see, we have functioning insulinoma, patients suffering from repeated attacks of hypoglycemia for 3 years. So surgery may be beneficial, but it will be so aggressive since insulinoma is benign condition. So distal pancreatectomy may be the solution. Pancreatic neuroendocrine tumor and intraductal pancreatic mucinous neoplasia with worrisome features are typically surgically management. Endoscopic EUS guided radiofrequency recently being developed. EUS guided radiofrequency ablation of pancreatic neuroendocrine tumor or pancreatic cystic neoplasm is safe with less than 10% complication rate, which can be decreased by improved prophylaxis for the procedure. Multidisciplinary team were held, and the decision was to do EUS guided radiofrequency. This case was done by our great mentor, Professor Dr. Hussein Okesha. We are in the second part of the duodenum, examining the head of the pancreas. Then this is the confluence of portal veins. This is splenic vein, superior-mesenteric vein, and the portal vein. Our lesion, as we say, are close to the confluence, but there was a long distance between to attack the lesion by radiofrequency ablation needle, and there was interposed ducts and blood vessels. So we swing to stomach station. This is the aorta, celiac trunk, and superior-mesenteric artery. Celiac trunk with its branch splenic artery, and the above is splenic vein. We do Doppler to confirm. Pulse wave show splenic vein. By anticlockwise rotation, this is a confluence, and close to it, our lesion in the neck of the pancreas. So our lesion in selenoma are at the neck of the pancreas. We do a Doppler to assess the blood vessels. Also, we take the measures of the dimensions. As we say, our track is there is no blood vessels, also no ducts. Pancreatic duct and CBD are distal to our lesion, so we will apply radiofrequency ablation and adjusting our needle. The needle will be connected to a generator of radiofrequency current adjusted at 40 watt. Our tip of the needle will puncture our lesion. As we say, we will begin at the periphery of the lesion. And while withdrawing our needle, we will apply the ablation to begin from the distal to proximal. This is the white bubbles of coagulation necrosis. We do a moving shot technique and fanning technique, beginning with the periphery of the lesions while withdrawing the needle, applying it from distal to proximal. And this is second pass. Also the white bubbles denoting coagulation necrosis of the lesion. And we assess for third pass. The upper part still need to be ablated. And I think we ablate most of the lesion. And this is the final view. Most of the lesion were ablated with the radiofrequency. This is the demonstrative video showing a moving shot technique. As I said in our real video, we start with the distal portion of the lesion while withdrawing the needle and fanning technique to attack all the lesion from distal to proximal. We can use fanning technique or multiple passes. And finally, we ablate mostly of the lesion. A rapid message. Potential application of EUS guided radiofrequency include pancreatic tumor, pancreatic duct adenocarcinoma, pancreatic neuroendocrine tumor, and pancreatic cystic neoplasm, HCC and liver metastasis, metastatic lymph node, cyst, adrenal gland tumor, and celiac plexus neurolysis. The value of destruction pancreatic net or pancreatic cystic neoplasm is to eliminate the risk of progression to invasive cancer and to avoid the risk of pancreatic resection. Pancreatic neuroendocrine tumor candidate for EUS guided radiofrequency, including pancreatic net less than 2 cm with histological proof, and the pancreatic net more than 2 cm in an operable patient or patient refusing surgery. Pancreatic net including insulinoma, gastrinoma, viboma, and somatostatinoma. While pancreatic cyst for radiofrequency, including IBMN, branch duct type with horizon features, and mucinous cystic neoplasm. Cystic fluid content should be aspirated first until a thin layer of fluid remained, thereby allowing targeting the remaining cystic lesion and decrease the injury to adjacent tissue. Prophylaxis for complication. Prophylaxis was introduced against acute pancreatitis, infection, and perforation. Rectal diclofenac to prevent post-endoscopic pancreatitis, as in RSV. Antibiotic prophylaxis to prevent infection of the necrosis. We use 2 grams of amoxicillin and clavulanic acid intravenous. Aspiration of the main part of fluid content prior radiofrequency ablation in polycystic neoplasm, in pancreatic cystic neoplasm or cystic pancreatic net, in order to avoid excessive application of radiofrequency current into liquid component to reduce damage to adjacent organ. Doppler assessment to prevent damage to interposed vessels. 2 mm distance was kept between any critical surrounding structures such as CBD and pancreatic duct and the tip of radiofrequency needle. Follow-up. Clinical follow-up was planned at 1 month, 6 months, and 1 year. Biological sampling of chromogranin A in patient with NET at 6 months and 1 year. Imaging was performed at 6 months and 1 year. with MRI for cystic lesion or CT scanning for pancreatic net. EUS was repeated at 1 year. Take-home message. EUS-guided radiofrequency ablation is a promising technique for small neuroendocrine tumor to avoid major surgery with significant morbidity and mortality. It is especially indicated in surgically unfit patient or patient refusing surgery. More comparative studies are needed before recommending EUS-guided radiofrequency as an alternative therapy to surgery for operable pancreatic masses or as alternative to chemotherapy in operable pancreatic masses. The main objective of this study are to investigate the safety of EUS-guided pancreatic radiofrequency ablation and to assess the efficacy based on 1 year follow-up imaging. And finally, thank you for your attention.
Any question? Dr. Muaz?
Okay, Dr. Ahmed, thank you for this presentation. It's really great work. It is not a question, just it's a concern or comment. As you will know, the pancreatic net, the most problem of net is distant metastasis. Yeah. I mean, unfunctioning net. So, just we should keep in mind during the development of this new technique, the impact of this technique on preventing metastasis in the future. Yeah. So, as you know, the Japanese guideline for NET, if the tumor more than 1 centimeter and not function, so of course, it's if functioning, surgery is recommended, yeah. And if not functioning more than 1 centimeter, we should resect. Less than 1 centimeter, we follow up. This guidelines was hypothesized based on the probability of metastasis. They notice the tumor more than 1 centimeter, most probably to metastasize, and less than 1 centimeter, less likely to metastasize. So follow-up is enough. So I just concerned about the dealing with the primary tumor itself. Maybe is not enough for the problems of NET. NET is the most problem is the distant metastasis. So in follow-up after 1 year, yeah. The CT finding no metastasis in your case, in this case. Yeah. Yeah. So
and for taking the decision, we have to do imaging and PET scan to assess if there is metastasis before applying or not.
May I have a comment? May I have a اتفضل يا خالد بس اديله الميكروفون بس.
يعني هو كلام دكتور معاذ طبعا. Yes, okay. يعني it's completely right that neuroendocrine tumor should be resected by surgery if more than 2 centimeter or more than 1 centimeter according to different guidelines. The different guidelines not accepting that less than 1 centimeter to follow up. The different between different decision options ما بين 1 to 2 centimeter. Accordingly, each society more than 2 centimeter, كله accepting for resection. In this case, we are talking about insulinoma with very rare or low incidence of metastatic incidences. So I think radiofrequency ablation, if the insulinoma is 2 centimeter or more than 1 centimeter, okay, it is ideal for radiofrequency ablation, especially in cases of difficult situation, difficult position, like in neck, like in this nice case done by Dr. Ahmed and Dr. Hussein, or head of pancreas. But in tail of pancreas, we can discuss that surgery, distal pancreatectomy, or whatever. But in cases of other neuroendocrine tumor, to be clear to the audience, more than 1 centimeter, more than 2 centimeter for surgical resection. More than 1 centimeter, according to the comorbidities of the patient, if he is surgical fit, you should resect. Less than 1 centimeter to follow up this patient. So the point is the metastatic incidence differ in insulinoma from other types of neuroendocrine tumor. Thank you.
I have a comment, Mr. Hussein. There are multicentric study done by Mark Partey and Mark Giovannini for about 30 patients done 2018 on cases of pancreatic net less than 2 centimeters and pancreatic cystic neoplasm, mucinous and IBMN branch type. And the success rate was about 70%, 6 months, and about 85% after 1 year, 70 after 6 months, and 85% after 1 year. And it was something odd, but they commented that radiofrequency may stimulate the immune system, not only local ablation, but also stimulate the immune system and the immunomodulators by taking the antigens in the lesion, and so the success rate was so high. Only 3 cases were complicated.
And inclusion criteria in the experience of Mark Partey and Mark Giovannini, the inclusion criteria were first tumors between 1 and 2 centimeters, as exactly Dr. Khalid Ragab said. Yeah. Less than 1 centimeter is follow up, more than 2 centimeters sure for surgery. And the second inclusion criteria is patient refusing surgery or patient poor risk for surgery. So even between 1 and 2 centimeters, the standard of care is surgery, but you can go to radiofrequency ablation if the patient refused surgery or if the patient is poor surgical risk. And I should stress the point of Dr. Muaz, Dr. Khalid Ragab, that the future, I think, and the ideal situation of radiofrequency ablation, as we did 5 cases, is in selenoma. Why? Because insulinoma is almost always a benign tumor. It's nearly never metastasized. And the patient is complaining so much, and the patient is poor surgical risk, and there is mortality and morbidity of major surgery, especially if it is the neck. If it is the neck, it will be extended WEPL or extensive subtotal pancreatectomy. So if you burn 80 or 90% of the insulinoma, the patient get rid of 90% of his complaint, and the rest 10% of the volume of the tumor will not metastasize. So I think the ideal will be in the future is functioning neuroendocrine tumor, especially in selenoma, because functioning gastrinoma and functioning somatostatoma have higher incidence or more liable to metastasis, as Dr. Muaz said. Yeah. So the ideal situation here is in selenoma, functioning tumor, especially in selenoma, because it's a very benign tumor and even will not metastasize even if you leave the tumor. But you should deal with the tumor because it is severely symptomatic and may be fatal. Yeah. So I think the ideal future will be in selenomas. Okay. Thank you very much for the interesting case done in Maadi Military Hospital, I think so.
Thank you.
Thank you very much, and thanks for the very precious comments of Dr. Khalid Ragab and Dr. Muaz. And now we will go to the last speaker, my dear friend and my dear colleague in our unit in Cairo University, Dr. Ahmed Al-Miliki. This is the last video, and thanks for your patience in staying till the end of the session.
Assalamu alaikum. I would like, first of all, I would like to thank my professor and my mentor, Dr. Hussein Al-Kasha, for inviting me today. And my presentation today will be an EUS guided liver biopsy is a paradigm changing. First and second, I would like to thank Dr. Hussein Yeto. He is head of advanced endoscopy unit at Baptist Medical Center, Boland Groover Clinic, Jacksonville, Florida. And I had the chance to work with him for 3 months.
ممكن تقرب بس من الميكروفون شوية؟
كده الصوت واضح؟
أيوه، شكرا.
Case presentation. 56-year-old female patient with multiple comorbidities, obesity, hypertension, diabetes mellitus, presented with right upper abdominal discomfort and worsening fatigue. She denies alcohol use. Physical examination displayed mild hepatomegaly with some tenderness to palpation. AST and ALT levels were moderately elevated. In conjunction with the patient presentation, elevated liver function test and radiologic findings, non-alcoholic fatty liver disease was suspected. EUS guided liver biopsy was selected for this patient. And here is the video. This is liver biopsy under EUS guidance. After the penetration of the capsule, you see here, we did single pass, single actuation. And this is a pathology specimen. And this is the pathology specimen after processing. So we sampled the left loop, and then we sampled the right loop. We sampled both loops with the same technique. So this is the pathology specimen, and the patient confirmed to have non-alcoholic fatty liver disease. So my presentation today will be introduction, EUS-guided liver biopsy, parenchymal disease, published studies, EUS-guided liver biopsy technique with new technique, and the conclusion. Introduction, EUS fine needle biopsy of the liver parenchymal disease has emerged as a safe and effective alternative to transjugular and percutaneous liver biopsy. EUS-guided liver biopsy can be used to evaluate both benign and malignant diseases of the liver. It offers the dynamic imaging and access to the liver with the option for Doppler assistance to reduce complication. So the approach, our approach is to the same approach as all mentioned the guidelines for liver biopsy. If you have negative workup with unexplained elevation of liver function test, or you have negative imaging, you proceed for liver biopsies. So what the options we have? We have EUS-guided liver biopsy. This is within the GI. Transjugular liver biopsy within the IR, interventional radiology, and percutaneous liver biopsy, it is between the GI and the interventional radiology. So why EUS-guided liver biopsy? It is safe, avoidance of the vessel using Doppler, complication rates comparable to percutaneous and transjugular, and the clinically effective concurrent EGD and EUS evaluation, and equal or superior specimen to transjugular and percutaneous technique, reduce sampling error by the ability to sample both loops, and improve the patient experience because you perform the procedure under sedation, and cost benefit, avoid an additional procedure, and grow the outpatient referral, and keeps the procedure within the GI. So the patient, any patient who needs liver biopsy will also need at some stage EGD for another reason, and the concurrent use evaluation of the pancreas for the gallbladder and the bile duct and other structure, and sedation also for liver biopsy and biopsy of both right and left loops, especially with large body habitus. And the contraindication, the usual contraindication that mentioned in all guidelines is low platelets and coagulopathy, significant ascites, and cirrhosis on imaging. So the criteria for adequate liver biopsy in most of the societies, recommended length is 2 centimeters, and the recommended completed border tract in the specimen is it is between 11 and 10 completed border tracts. And the current methods, percutaneous or transjugular, achieve these results. But the percutaneous biopsy has major problem, so that the adequate biopsy in one study that included 2,796 patients was nearly 20%. You see, 80% of the specimen were not adequate. So we have to find another modality to achieve the adequacy of the biopsy. So in one study that compared between EUS and other methods of percutaneous transjugular technique, the EUS guided biopsy shows superiority over percutaneous and transjugular, as you see here in the diagram. And also in another study, in comparing the three techniques, EUS guided biopsy showed superiority in terms of the number of complete border triads, and the mean aggregate length, and the mean length of the longest intact core, and showed less time for the recovery of the patient. So how to access the right loop and left loop? It is very easy. In the left loop, you have to identify celiac axis. So then you do 90 degrees counterclockwise rotation, and you find the left loop. So the second thing is you have to identify your trajectory. You can do this using Doppler in order not to have any vascular structure that oppose you during EUS guided liver biopsy. For the right loop, you have to reach the supraduodenal apex or supraduodenal gall, and you can torque your scope to 100 degrees in order to clockwise rotation in order to have your right loop, and you do the same technique in the right loop. So why we are sampling both loops? Is one loop enough? I think it is not enough because the phenomenon of sampling error. So in a study performed on 124 patients, there was a grade difference and stage difference, meaning that there is maybe one loop has a stage ahead than the other loop. In another meaning, one loop can have stage 3 fibrosis and the other loop can have stage 2 fibrosis. So you have to sample both loops because the process is not uniformly affect both loops. And this another study that proved this point of view. There is a single right loop liver biopsy underestimated fibrosis in 25% of the patients. And also, this is also another study that the review that was done, and the diagnosis accuracy was 93.9% in EUS guided liver biopsy. And there is another study showed comparison between single pass and one actuation and single pass 3 activations. And EUS liver biopsy was done in 40 patients, 1 pass, 1 activation, 1-to-1 versus 1-to-3 activation to an FNB needle. EUS liver biopsy using 1-to-3 technique produced longer liver course with more CBTs, complete portal tracks, than 1-to-1 technique with an equivalent safety profile. Which needle we can use? In this meta-analysis systematic review, concluded that the best needle you can use is 19 gauge needle Acquire. So they have less complication and longer adequacy of the specimen and longer core biopsies, and also they have more completed border tracts. What about the adverse events? The most common adverse events for this technique, for the EUS guided liver biopsy, is abdominal pain, which is controlled by analgesia. And also bleeding is not much common. It is 1 to 2%. And bile leak is one reported cases. And you have to take care because you can sample the spleen. It happened in 2 reported cases. What about correlation of EUS guided liver biopsy with another non-invasive techniques like magnetic resonance elastography? This study evaluated this and showed the MRE correlated by 68% with EUS guided liver biopsy. And in another study, MRE correlation showed 83%. This means that you still have 20% of the patients have false results by using MRE correlation. So I think you can change your mind now if there is any advantage of the different techniques in comparison to EUS liver biopsy. So what about the technique? The standard technique, you have to prime your needle with heparin first, and you can do multiple activation. This is the standard. This NETO technique, it is 1 pass, 1 activation with suction technique. You can then remove the stylet and prime the needle with saline, not heparin, and the EUS examination with the Doppler to identify both loops and the planned trajectory of the needle. 1 quick, forceful activation into the desired loop, just 1. After penetrating the liver capsule, as we showed, as we saw in the video, then you then put your syringe and turn off the suction after 1 centimeter withdrawal, or when the saline is observed in the syringe, in order to the specimen, in order to render it floating, so it can easily sucked into the needle. What about the patient follow-up? It's easy also. You can the patient can stay in the recovery room for 3 minutes. Antibiotics were not given. and phone follow-up for after 48 hours post-procedure, and the patient will follow up with you after 2 to 4 weeks post-procedure. And the specimen preparation, you just put it in the formalin block. So in conclusion, EUS liver biopsy is an emerging alternative or soon gold standard for liver biopsy. EUS guided liver biopsy is safer, more efficacious in terms of complete portal tracts and total specimen length compared to percutaneous and transjugular technique. EUS liver biopsy has the ability to sample both loops, which is important in fatty liver disease. Nieto technique met 100% EASL and AASLD criteria in 420 liver biopsy patients. Post-operative pain relieved in 100% of the patients with analgesia medications, and major complications like bleeding the incident was low. And what about we can push the boundaries of the EUS guided biopsies to include also the kidney? We can also sample the kidney, EUS guided renal biopsy, and I was lucky to have witnessed this case with Dr. Nieto. And we sampled the kidney, and it was a focal segmental glomerulonephritis. And I think the future for the EUS for renal intervention. And I think this is pushing the boundaries of the EUS much more. And thank you.
Thank you, Dr. Ahmed. There's a new technique, and we are now only a few seconds or 1 minute left, so we allow for only one question. Only one question.
Thank you, Ahmed, for this nice lecture.
Thank you.
Excellent. But there are some secrets about the heparin, the saline. You prime the needle with heparin and saline?
No, just saline.
Just saline.
Yes.
Yes, and
in the hip, it is no difference between heparin and saline.
What's meant by actuation?
Actuation, it is the work, the movement. The pass is when you put insert the needle into the tissue. This is a pass. Okay. If you withdraw the needle and enter again, this is another pass. The actuation, when you perform a biopsy, then a biopsy, you have 20 actuations. This is actuation. This is the movement.
To and fro movement.
Yes, to and fro movement. This is called actuation.
Okay, then thank you very much. This is a new technique worth us to study and worth us to have to pay attention.
Yes.
And at the end, now coming to the end of the session, exactly in time. Thank you very much for your attending to the last minute. Thank you for very valuable discussions and raising a very important points and sending very clear messages. So thank you all colleagues. Now come to the end of the first day. Tomorrow will be in Al-Hussein Hospital, Azhar University, 9:30 in the 7th floor. And now it is a time for lunch. Now it is a time of lunch. And thank you very much.
Thank you, the professors.